Good morning. I'm Kayla Borchers, and I am a physical therapist at The Ohio State University Wexner Medical Center. I would like to welcome you to our annual Sports Medicine Treatment of Endurance Athletes Symposium. This year, we are excited to be able to bring you this symposium virtually. We have an amazing lineup of speakers for you today. So I want to quickly share a few housekeeping notes so we can get started. You will remain muted and your cameras will be turned off for the duration of the webinar. This session will be closed captioned and recorded for viewing at a later time. As you listen to the presentations, please feel free to type questions you have about what you're listening to into the Q&A box. At the end of each segment of presentations, our experts will answer as many questions as possible during the Q&A panel. I will serve as the moderator for today's event. I am a physical therapist and have been at the Wexner Medical Center for 4 years. Currently practicing out of the Jamison Crane Sports Medicine Institute. I'll be with you all day, leading you through our packed schedule and offering some opportunities to interact with us with poll questions throughout. Without further delay, I'd like to welcome Dr. Tim Miller to really get us started this morning.
Well, good morning, and thank you for being here today. And I'm just so excited for this program. You know, we started back in 2014 with our original program when it was first founded. We were at the OSU football stadium at the time, and things have evolved so much over the last 7 to 8 years, and we've now gone virtual and set a record for the most registrants we ever had. So besides that, we've got a huge lineup of great people, great speakers. One of the things I've mentioned every year of what makes me so proud about this program is that all of our speakers, other than our keynote speaker, Dr. Hutchinson, are experts from right here at the Ohio State University Wexner Medical Center. We know that over the last several years, and really the last 10 years that our program has been developing, we've become a beacon for the treatment of endurance athletes, not only locally in the Columbus area in Central Ohio, but also throughout the entire state of Ohio, and really now more and more of the Midwest, and becoming more of a national footprint for bringing in athletes who participate in endurance sports and need that treatment to recover from injury and optimize performance. So we're looking forward to the day that we're having in front of us. Please make sure that throughout the day you ask questions. Don't be afraid to do that. That's very much encouraged. We're also going to have our evaluations that you'll be emailed after the program is over. So please fill those out. We want to make sure we do the best we possibly can in order to get the best program out there each and every year. So without further ado, we'll move forward with our program. We'll start maybe just a couple of minutes early here, and we'll start with Dr. Hutchinson's talk after Kayla introduces him. Great day.
Yeah, thank you, Dr. Miller. We are proud to welcome a distinguished and accomplished medical professional today, Dr. Mark Hutchinson. Dr. Hutchinson is a professor of orthopedics and sports medicine and adjunct professor of orthopedics and sports medicine and family medicine at the University of Illinois at Chicago. He is dual certified in both orthopedics and sports medicine. Dr. Hutchinson has been in practice for 25 years at the university, where he has served as head team physician for all sports and director of sports medicine services. In addition to his services to the sports teams of the University of Illinois, Dr. Hutchinson has served Team USA at the Olympic Games in Rio, the Pan Am Games, the Paralympic Games in Torino, the World University Games in Serbia and Thailand, and the USA gymnastics team at the Olympic Games in Atlanta in 1996. He has also served team physician roles with USA Basketball, USA Soccer, USA Gymnastics, USA Field Hockey, the WNBA Chicago Sky, the University of Kentucky, Eastern Kentucky University, and numerous other local and regional schools and events. Dr. Hutchinson is a fellow in the American Academy of Orthopedic Surgeons and is an active member of the American Orthopedic Society for Sports Medicine and the Arthroscopy Association of North America. He is immediate past president of the Orthopedic Learning Center and was co-founder of the Arthroscopy Association of North America's Fundamentals in Arthroscopy courses, for which he continues to serve as master instructor. Dr. Hutchinson is a fellow and past vice president and current presidential candidate of the American College of Sports Medicine. Dr. Hutchinson is a dedicated educator and has received a number of teaching awards. He has worked for over 25 years with medical students in the University of Illinois College of Medicine, as well as supervised or participated in the education of over 175 orthopedic residents, 40 primary care sports medicine fellows, and 20 orthopedic sports medicine fellows. He has co-edited 3 books and authored 35 book chapters, nearly 100 peer-reviewed publications, and over 250 book reviews. Please join me in welcoming Dr. Hutchinson.
Thanks so much, Kayla. I don't think I've ever heard such a wonderful introduction. I don't even know who is speaking to you. But with that, it's really a pleasure of being part of this amazing symposium from Ohio State University. I thank you and Tim and the entire group. You guys have created a go-to conference here for this endurance athletes. I think it is beyond Ohio State and the state of Ohio. Other people certainly know about it around the country, and it's a privilege to take part. I'm going to begin really kind of introducing and bringing everybody into a topic that I think we see too commonly in our endurance athletes, and that is leg pain. For you, just so you know, again, you've had that wonderful introduction, a little bit about my credits with leg pain. I've been working with athletes with leg pain for about 27 years, and I think I'm not sure if it was the smart move or the dumb move many years ago, and that was I had an athlete who presented with leg pain, and it really had not been worked up particularly well. Nobody understood it very well, and it really became a niche for my research and a niche for my interest. And then over the years, across the city and across the Midwest, I'll have people send me athletes with leg pain because it's a fairly unusual or not a fully understood problem. And that I think as we walk through this diagnosis today, you'll be able to be more specific about the diagnoses as well as then more optimize the treatment. So just to begin, I have no corporate disclosures. I will have to admit that the University of Illinois does get some funding from corporate for our resident and educational events, but I don't take anything. I do participate on a number of sports medicine boards as part of a reviewer or on the executive boards. So my goal to walk you through here is to optimize the outcomes of when you have exercise active patients, could be athletes, could be soldiers who present with leg pain. And the key is going to be to make an accurate diagnosis. That's what's going to guide you to the appropriate treatment and then get them past their problem. You have to be very careful if we're looking for overlapping diagnosis, because in leg pain that can occur. And by choosing targeted evidence-based treatment plans is going to be our best opportunity to have a good success with our athletes. Finally, when it doesn't fit and things are a little bit weird, that's when you have to consider a broader differential diagnosis to come up with the best treatment plan. So exercise-related leg pain is common among athletes. About 15% of runners and endurance athletes will develop some type of a leg pain. And I would encourage you to avoid a term, and that is shin splints. I think you're going to have a lot of your athletes come in and go, hey, I have shin splints. For me, shin splints means I have leg pain. I don't think it clarifies anything particularly. There is a subdiagnosis, medial tibial stress syndrome, that probably is directly related to this diagnosis, but it's not very specific. So I'm going to encourage you to listen to your patients when they say it, and then try to get a more specific diagnosis to guide your treatment. Understanding leg pain, certainly we have to think about the different potential sources of leg pain. So it can come from the bone, which has a continuum of bone trauma, existing from bone strain to stress reactions to actually a stress fracture. Now we're going to have a nice talk on different approaches to stress fractures, and that's going to be a minimal part of my talk. I'll mention a couple things with it, but I'm going to really defer to Dr. Miller in terms of some of the approaches to stress fractures. But you can also get periosteal problems, which is an inflammation of the periosteum, which is it could be a broad stress injury of the bone, and it may be a traction injury from some of the muscle attachments. Then within the leg itself, you have 4 to 5 muscle compartments. Here you can get chronic strains, you can get acute ruptures, you can get chronic tendinopathies. And probably the thing that we worry about as that I see as something that's been missed a lot is exertional compartment syndrome. And then you have within those compartments, you have very specific nerves. And in fact, if you have problems within the compartment, you can be able to tell by the distribution of the nerves which compartment is probably involved. We have to think about more broadly extended differential diagnoses. For me, I'm going to think about 4 common problems in most of our athletes, and they're going to be stress fractures, they're going to be exertional compartment syndrome, it's going to be popliteal artery entrapment, and then it'll be a muscle strain. When they don't fit those things, then I have to start thinking about this broader extended differential diagnosis. Pain syndrome, it could be perineal neuropathy or Charcot-Marie-Tooth disease, some peripheral nerve entrapments, but those are going to be less common. And so I have to rule out those other common things first. Anatomic sources, clearly we have to think about the vascular system. You can get popliteal artery entrapment syndrome, and we're going to talk more specifically about that in our athletic population. In older populations, you think about atherosclerosis, and for a variety of reasons, we can't miss the diagnosis of DVTs as a potential source of problems, particularly in our maybe mature women athletes who are on oral contraceptives, and some other issues that place some risk of DVTs. And then part of this broader differential diagnosis that we have to consider is then when you start getting this, really it's muscle aches and pains, muscle broader things. It's not in the bone, it's not neurologic. And then that's when we're going to start thinking about dehydration, some electrolyte issues. And I know we're going to have a separate talk today about rhabdomyolysis. Also some atypical presentations, but very critical things to be aware of. And then lastly, in terms of this broad differential diagnosis, we really don't want to forget about the zebras. Again, somewhere on in-training exams or board examinations, they do like to throw in some question that says, golly, things weren't getting better. The person just would wake up at night with pain. They have atypical swelling, and then you get an x-ray and you see something that's abnormal. These are things that you don't want to miss. And again, they're probably going to be the things that don't respond to classic soft tissue early treatment that we would have with ice and rest and elevation. These things continue to progress and continue to get worse. So we don't want to miss them. So we want to be alert to them, but it's probably not going to be that common. And then the last thing we want to be looking at very carefully is associated factors. We have these broad differential diagnosis. And once we have leg pain, and you're going to work that up in your office, probably the worst thing to do is to actually jump quickly to a singular diagnosis, think you have the treatment, and then just treat the stress fracture. Because if you do that, then we're going to potentially miss these other long-term issues that increase the likelihood or lead to a potential recurrence. And they include lower limb alignment, gait mechanics, particularly a history of training intensity. Most of these problems happen with a ramp up in training, an increased load, especially an acute increase compared to their chronic baseline. Shoe wear can make a difference. And I've had a number of athletes who come in and we have some working diagnosis of some overuse problem of stress fractures or something. I simply change their shoe wear and their problem goes away. Similarly, that interaction with the court surface may play a role. And then as we think about the broad differential diagnosis, age and gender, we have to think about because there's some variations between the diagnosis by age and by gender. This was a study by Carrie Hamster Wright, one of my associates at UIC, who looked for some factors associated with leg pain. So she did a systematic review and meta-analysis of 21 different studies and noted that just leg pain in general was increased with people with BMI, increased with females, increased with patients with pronated feet, increased if you had hip external rotation, and increased if you had increased plantar flexion. And so all of these different factors play a role that you're going to want to look for as you're working up these athletes and trying to prevent recurrence of problems. And then one of the messages I try to leave to everybody is this concept of overlapping diagnoses. I think we have to be very careful here, and that is because I've seen a number of people who present We think they have exertional compartment syndrome. It's a little bit borderline. And then actually, when you get your x-rays and you get your workup, you actually see bone edema or you see some problem in the bone. And what actually was going on was you had a stress injury of the bone. It caused swelling within the compartment, put them over the edge of exertional compartment syndrome, and they actually had both. But the problem, the key is you didn't really want to jump to surgery for the compartment syndrome. You needed to take care of the underlying stress fracture. Once you did that, the problem went away. So I want to pay attention to that potential, especially with leg pain. Some clinical clues that's going to guide you to these different diagnoses. Pain with first impact. So I have them jump, land on their heels, or they say, hey, if I sit, it's not too much of a problem, but right when I start to play basketball and land, it bothers me. Then I think about a stress fracture. It can also occur with periostitis. If they have diffuse medial pain. So if they have focal pain and you can take your thumb or your finger and you can pick one spot on the bone and it hurts, I'm thinking about a stress fracture. If it's actually broad, I can't cover it with my finger. It covers really more 2, 3, 4 centimeters long, particularly on the posterior medial border of the tibia, then I'm looking about medial tibial stress syndrome. Focal muscle pain, you think about the muscle strains and potential muscle hernias, focal tendon pains, chronic tendinopathy. They have pain with resisted motion. This is when you're going to have, you probably have a muscle strain, maybe some tendinopathy. If you have the old tuning fork in your pocket, or in all honesty, if you're using therapeutic ultrasound, sometimes when you put that device directly over the bone, that vibration will irritate a stress fracture. It's an interesting clue. Probably the other thing we pay attention to in these athletes that's going to clue me in a lot is not the pain with first impact, but it's pain with exertion. And so these are the athletes that say, I have no problem at all. I start to go on my run, still no problem. 5 or 10 minutes into my run, I have a problem. It starts to pain, it starts to get tight, and then finally I have to relax, sit for a little bit, and it goes away. That's a pretty classic story for exertional compartment syndrome. If it actually is in the back, in the calf, it could be a deep compartment syndrome, or it could be popliteal artery entrapment. So I have to consider both of those. Sharp electric pain, shooting pains, and you can't miss those radiculopathies or nerve entrapments proximally, burning pain, infection, inflammation, pain at night, things that wake them at night. Now you have to think about those zebras and potential tumors and things like that. Motor weakness, think about muscle tendon ruptures, herniated discs. Again, paresthesias, those sharp lightning bolt pains, we're thinking about nerve issues. Paresthesias with exertion, anything with exertion, my first things are going to be thinking about exertional compartment syndrome and popliteal artery entrapment syndrome. How about diffuse swelling? Broad swelling, not even focal. If it's focal swelling, then you can think about a ganglion or muscle herniation. If the whole leg is swollen, it's vascular. It's vascular until proven otherwise. Even if it happens just because of exertion, they get swelling, it's still vascular. It just happens to be exertional compartment syndrome. So you have to think about those broad things. Cramping or spasm, now that's just different. This is not these focal pains. This is when you first think about dehydration, electrolyte imbalance. If it's chronic, again, think about rhabdomyolysis as potential issues. And then think about these atypical populations, the masters athlete, the older population, they're more likely to have some chronic tendinopathy, chronic overuse, and potentially issues with vascular claudication. Women athletes, particularly if they're on oral contraceptives, think about the potential of a DVT. So let's talk about a few of these different diagnoses a little bit more specifically, and probably the one that I see come up, and I see it come up because I think it's commonly missed. These are the athletes who come in and they say, I have shin splints. They were treated by 12 different people. They tried rest, they tried bracing, they tried nonsteroidals, nothing seemed to work. And somebody didn't really think about exertional compartment syndrome. So exertional compartment syndrome is consistently exercise induced. It's commonly in endurance athletes. It accomplishes about 27 to 33% of leg pain in athletes. They have no pain at rest, and it gets better. No pain at rest, worse with exertion, and then gets better again. We want to pay attention to, though, this issue of potential. What's the difference between exertional and acute compartment syndrome? And acute compartment syndrome, you have these tight groups of muscles, 4 groups of muscles in the leg. and maybe you had a fracture and you bleed into that compartment, and the pressure increases so much that it cuts off the circulation. This is a surgical emergency. This is something that needs to go to the emergency room. It needs to be decompressed immediately. Exertional compartment syndrome is not that, because generally it waxes and wanes. But we have to be very careful. There's been numerous cases that are described, oftentimes medical legally, where somebody came in and they were hiking. They didn't run, they didn't do their endurance athletes. They chose their activities very much. They chose to run that marathon. And the next thing you know, at the end of the marathon, they had leg pain and it won't go away. And it's getting worse. And everybody goes, well, maybe he has a stress fracture. Maybe he has medial tibial peristitis. Maybe he has something else. And they forget this diagnosis. And what happens is you can have an exertional compartment syndrome convert to an acute compartment syndrome. Those, again, are surgical emergencies, need to be addressed. Otherwise, they're going to lose their syndrome, called the anterior and lateral compartment. So generally, these athletes are going to present with, again, pain with an anterior and lateral aspect of their leg with exertion. Plans for exertional compartment syndrome, and particularly in the military population, is this concept of forefoot running. Originally, D-Ball and Breen had 10, so very small groups, so very low evidence. But what they found was that they changed from a heel-toe running style to a forefoot running style. People who had symptoms and a clinical path that looked like exertional compartment syndrome, they could actually reduce that incidence and ultimately have no need for surgeries and reduce pressures. And so because of that, our buddies in the Netherlands actually have changed and modified their treatment program by reducing provoking symptoms, reducing local pain and limitations in the surrounding joints, improving whatever risk factors they can, including changing running styles. And so they did retrained soldiers by giving them better shoes and boots. They adjusted their running technique to a more of a forefoot style of running. And what they found, it had significant decrease of pain complaints. So they felt that it worked both for exertional compartment syndrome and medial tibial stress syndrome. They had decreased pressures. And for them, what was probably one of the most interesting findings was this, is that they had a decreased total number of fasciotomies. They decreased their need for fasciotomies by 80%, and they had a 60% return to full active duty at 2-year follow-up. And so they were able to have these patients who had exertional compartment syndrome or symptoms like them, and then avoid surgeries by doing a non-operative approach first. Instead of jumping to surgery, they did a non-operative approach. What was interesting, though, in their studies, that they still found after that time, even though they had returned to active duty, a lot of these people still had symptoms. So they weren't normal, but they were able to avoid fasciotomies and return to active duty. So in terms of the surgical choices, personally, we actually developed a technique that was used endoscopically assisted. Some people would use a single incision, some people do 2 incisions. We were able to do 2 small incisions, endoscopically assisted, and over that time, as long as you get 80 to 90% release of the length of the fascia, you can get good to excellent results. Historically, we've said 80 to 90% good to excellent results, slightly less in female athletes because of a study Lyle McKaylee did in 1999. Here you can see some outcomes, 81% positive results with surgery, 41% if it was treated non-operatively, better outcomes in collegiate level athletes, and particularly excellent outcomes if it's isolated anterior compartment. You do have to be careful of the posterior compartment issues. If they have that posterior issues, success rate drops significantly and maybe is only 35 to 60% successful. I think what we see here, and this is one of the pressures for why the military did change their pattern of treatment, is because they had, in this study by Waterman, only about 41% return to active duty. They had a 44% recurrence. And so they didn't do very well with surgery. And this is going to be seen in a variety of different military studies that the outcomes from surgical releases were poor, which is exactly why you see the work from Zimmerman in the Netherlands, who looked at other options. But why is it so bad? Why is it that they had challenges? Well, I think it's a complex issue. It can be that they have misdiagnoses or overlapping diagnoses. There is potential issues of secondary gain, and it may just be the rigorous demand that they have. My personal experience is not that bad. I've done over 400 endoscopically assisted surgeries in the last 25 years. I have 90% success rate. These are all followed by the residents at greater than 2 to 4 years. We've had some local complaints. I had some operative cellulitis, generally treated with antibiotics. We've had some postoperative stiffness, treated with deep friction massage and physical therapy, generally resolves, but generally have very happy outcomes. So it certainly can be very successful. So as I have about 10 more minutes to share with you. And while I have that special interest in exertional compartment syndrome, I want to cover a few other diagnoses that you want to think about that an athlete may present with. One of those is a muscle herniation, and you're going to see potentially, like you see this small little bump out over here, may be related to trauma. A muscle herniation is often related to exertional compartment syndrome. It's your own body's attempt to release the fascia. It's oftentimes a low anterior lateral aspect of the leg. This is actually where the superficial peroneal nerve comes from deep to superficial, creates a little weak link in the fascia. You can diagnose these fairly well with an ultrasound. You can see where the defect is. In general, if they are symptomatic, they have associated paresthesias, repair of the fascia doesn't work. You really just need to kind of do a fascial release like you would do it for a compartment syndrome. Popliteal artery entrapment syndrome. Now this is really an arterial issue. The artery can get pinched, and we'll show a picture here of a variety of the areas the artery can be pinched. They present with deep calf pain, usually upper calf, worse with exertion, gets better. I ask them if they have a sense of a whoosh, a warm rush after exertion. They get tight in their calf and they feel that they have a warm rush to their foot. That could be just the flow of circulation coming back. Here you can see the variations. Here's pretty normal right down the middle of the two heads of the gastroc, but you can see it branches out around the medial gastroc. It could go through the medial gastroc. There can be fascial bands. There's a variety of things that can pinch on the popliteal artery in this location. So you just have to think about it. I'll get out my stethoscope. Yes, an orthopod using a stethoscope. I'll listen for a potential bruit. My favorite thing to do is to get a Doppler ultrasound. And what I'll do is I'll have my patients actively plantar flex or dorsiflex. And you can see as they actively plantar flex, the arterial Doppler disappears. And then as they relax, the artery pulse comes back. Pretty easy to do. And you can kind of see it on your own. Ultimately, that's not the way I'll confirm the diagnosis. I will confirm the diagnosis with an angiography, an MRA, actively with active plantar flexion and dorsiflexion to see if it actually cuts off the circulation. If it does and it's a problem, again, people have actually discussed Botox here, but most of the time it's a surgical release of this anatomic variant that's causing the problem. If it's anatomic, you have a structure there, you have a 90% success rate. If it's really just functional for some other reason, the success rate's about 77%. Now, I know that Tim is about to tell us about some unusual or some approaches to stress fractures. I'm not going to hit on that because I'm just going to pass this over, but I do want to hit on two different points. One is in your female athletes, the most common presentation of a female athlete triad or relative energy deficit syndrome to orthopedic surgeon and to musculoskeletal primary care doctors is actually a stress fracture. And so if you have a female athlete with a stress fracture, you have to think about the potential about female athlete triad or relative energy deficit. It's 8 times more common with eating disorders. If they have hormonal dysfunction, it's 2 to 6 times more common with those problems. So I have to consider that. And then ultimately, if you have some stress injury, don't play through pain. You can get some type of a catastrophic injury. So again, I will talk briefly about medial tibial stress syndrome. This is exercise-induced pain in the mid to posterior leg, just at the posterior medial border of the tibia. There's a variety of factors. We talked before about these associated factors, and this is probably the most important diagnoses that I really look for: anatomic alignment, varus hindfoot, excessive forefoot pronation, femoral anteversion, tibial torsion, all can contribute to this. And therefore, sometimes orthotic wear can actually assist in avoiding these problems. It's relatively rare before age 15, and it can make up about 13 to 42% of athletic leg pain in athletes. The actual pathology is unclear. Some people think it's a traction injury from the soleus or FDL. It's probably a diffuse bone stress injury rather than just a focal stress fracture. For me, the treatment is similar to my stress fractures. My first line of treatment is a knee-high air stirrup, which will try to share the load. I don't use anti-inflammatories. I will use some topicals. I think for most bone injuries, I think that anti-inflammatories may actually slow the healing response. So I use alternative treatments for pain management. And then you'll want to do some type of stretching. People have talked about prolotherapy, PRP, mesenchymal stem cells, but there's not absolute great evidence to support it. Most of the time it gets better with rest. Surgical choices like periosteal ablation, I've done extremely rarely, and it's really kind of a treatment of don't miss this one. Happens more commonly in the older population, potentially obesity, oral contraceptives. They have posterior calf pain, they have diffuse swelling, they have redness, can be with recent travel, can be associated with surgery. These are going to be dangerous. And what we also know with DVTs is it's actually common that, or it's not uncommon that we don't have a classic presentation. They don't have all of these things. And so if I have even the suspicion of a DVT, I'm getting a venous Doppler on every single one because sometimes they're asymptomatic. Vascular claudication, older population, 5% of males over 50 have intermittent claudication. Interestingly, they can respond to lipid control and antiplatelet medicine, good diabetes control, and decreased smoking. Muscle cramping, you're going to get a little bit more of this in the talk from Dr. Walrod about rhabdomyolysis. But if they have muscle cramping, I do think about metabolic abnormalities. I will check their hydration, potassium, magnesium, calcium. Think about thyroid myopathy. Consider a delayed onset muscle soreness because of overuse and overuse training. I think you have to think about all of those. And then we talked about before those atypical things, those tumors, looking for night pain, atypical pain, things that aren't responding to those classic treatments. So as we start winding down, we want you to think about creating a plan of attack for atypical pain. You want to recognize it, create a broader differential diagnosis rather than the common ones, and then think up of a targeted workup. So I'd like to just kind of leave you with what I'm going to say is the key 10 lessons that I've gathered with leg pain. One is avoid that non-diagnostic terminology. Let the athletes talk about shin splints. You come up with a specific diagnosis because that's going to guide your treatment to give best outcomes. Think anatomically every time. So it's which compartment, what nerves in the compartment, which muscles involved. That's going to, once you think anatomically, it's going to give you the best approach to your treatment and best outcomes with your patient. Common things are common. Top 4 causes of leg pain in athletes are going to be stress fractures, exertional compartment syndrome, popliteal artery entrapment syndrome, and muscle strains. However, when things aren't typical, think about the zebras. Also, then be aware of those overlapping diagnoses: exertional compartment syndrome, medial tibial periostitis, medial tibial stress syndrome, and stress fractures. Those overlapping diagnoses, if you miss one of them, you can still have a failure. So you need to be able to identify everything that's going on to optimize treatment. And then once again, consider all of those contributing factors. If you really want good outcomes, think about what caused it in the first place. Did they have abnormal alignment that you can correct with shoe wear, improve their cushioning? What was their training intensity? Probably the biggest cause of overuse problems of the stress injuries of the bone. If you modify that, the problem can go away. You want to target the most likely diagnosis. whether that's stress fracture, exertional compartment syndrome, as you target that right, the proper diagnosis. And then one of the things particularly, I think even for my non-surgical, my non-surgical primary care partners, but any orthopedic surgeon, any emergency room doctor, don't be afraid to test. It's easy. Yes, it's a little bit painful, numb up the skin, but always test all 4 compartments. Always do pre and post testing, because you don't want to go say, hey, I've made a diagnosis in the anterior lateral compartment, and then just do that surgery, and then they fail because you didn't treat a deep compartment. You want to reorient the needle back to the exact same position every time so it's reproducible, and then make those measurements. Always screen first-time stress injuries in female athletes and soldiers for potential female athlete triad or a relative energy deficit. If you treat that underlying problem, their problem can prevent recurrence. Best evidence available when choosing treatment options. Always go with the best evidence available, and be open-minded. I mean, I was a surgical guy that says you have exertional compartment syndrome. All of those other things don't work. Let's go to surgery. I've become much more open-minded, and even co-authored a couple of papers with Wes Zimmerman, looking at this sports medicine non-operative approach first to exertional compartment syndrome to try to see if we can reduce the number of surgeries that are being done. And then lastly, really look at a team approach to all of it. This is going to include the surgeon when you have to. It's going to include imaging for things like the popliteal artery entrapment syndrome. And then the first line treatment, as we all know, is going to be the athletic trainer, the physical therapist, those people that are treating it. This is the team that took care of Team USA in Rio. And we just wouldn't have gotten by with all of those athletes without everybody taking and doing the best they can in their part. So with that, thank you very much, and go Team USA in Tokyo.
Thank you, Dr. Hutchinson. What a great talk. To keep us interactive with one another, we're going to do poll questions based on the talk you just heard. We'll do these throughout the day. You will see a poll question pop up on your screen shortly. Select the best answer by clicking it, then clicking submit. We'll give you a few moments and then share the answers with you. So hang tight as that is getting pulled up. First question, which of the following is most suspicious for the diagnosis of exertional compartment syndrome? Anterior leg pain exacerbated by jumping and hard landing. B, anterior leg pain 10 minutes into a run. C, anterior medial leg pain made worse by running on hard surfaces. D, posterior leg pain with associated lower leg and foot swelling. Or C, lower posterior leg pain when standing on tiptoes. So I'll give you a moment to answer here. I'm seeing some good answers coming through here. And the majority has it. The correct answer is B. A is likely a stress fracture. C is likely medial tibial stress syndrome. D is likely popliteal artery entrapment syndrome, and E is likely Achilles tendinopathy. Let's do another. This one is still number one. Wait for that second question to appear here. Second question. Which of the following intracompartmental pressure measurements are most consistent with exertional compartment syndrome, but not acute compartment syndrome in a patient whose blood pressure is 120/80? A, at rest, 60 millimeters of mercury, immediate post-exertion, 75 millimeters mercury, 5 minutes post-exertion, and 60 millimeters of mercury. B, at rest, 10 millimeters of mercury, immediate post-exertion, 17 millimeters of mercury. 5 minutes post-exertion, 15 minutes of mercury. At rest, 18 millimeters of mercury. Immediate post-exertion, 32 millimeters of mercury. or 5 minutes post-exertion, 25 millimeters of mercury. D, at rest, 15 millimeters of mercury. Immediate post-exertion, 65 millimeters of mercury. 5 minutes post-exertion, 60 millimeters of mercury. Final option, at rest, 50 millimeters of mercury. Immediate post-exertion, 20 millimeters of mercury. Or 5 minutes post-exertion, 18 millimeters of mercury. This one is a challenging one. So click your best answer and click submit. And by a slim margin, oh, it's going back and forth. The majority had it and still has it. The best answer is C. A likely represents an acute compartment syndrome. B is likely normal. D is someone who may have converted to acute compartment syndrome with testing. And E is likely an aberrant first reading since the pressures go down and stay down with subsequent testing. All right, we'll do one more. Final question for now. What % reduction in surgical fasciotomy can be expected by performing a non-operative first approach for soldiers with leg pain? Go ahead and select the best answer and then click submit. That's right. The correct answer is B, 80%. Oh, we ended up having a tie. 80% is the correct answer here. So that'll do for poll questions for now. You were welcomed this morning by our next speaker, Dr. Tim Miller. Dr. Tim Miller is a board certified and sports medicine subspecialty certified orthopedic surgeon at The Ohio State University Wexner Medical Center. He received his medical degree from Wright State University School of Medicine in 2005 and has been in practice for 10 years. He specializes in surgical and non-operative treatment of orthopedic sports medicine injuries and conditions of the shoulder, elbow, knee, leg, and ankle. He has served as team physician for the Ohio State men's and women's track and field and cross-country teams since 2011. He is head team physician for Capital University Athletics, the physician lead for Ohio State endurance medicine team, and a consultant for the U.S. Olympic team. He was named a Castle Connolly Regional Top Doctor in Orthopedic Surgery for 2020 and has been rated in the top 10% of physicians nationwide for patient satisfaction several times. Dr. Miller is an internationally recognized expert for the treatment of stress fractures and other overuse injuries. Please join me in welcoming Dr. Miller.
Thank you, Kayla. I'm going to share my screen here if we can. All right. Now the poll is still showing up in the middle of my screen. Is there any way to get rid of that before I start my talk?
You can hit the X button and it should disappear.
Okay. All right, great. Thank you. So thank you for the warm introduction. I really appreciate it. And I really appreciate Dr. Hutchinson's talk and reassuring me that there are other orthopedic surgeons out there who treat the same kind of problems I do in endurance athletes, and have the same kind of interest in stress fractures, leg pain, and exertional compartment syndrome, as well as PAES, or palpable artery entrapment syndrome. There aren't a whole lot of us out there that treat that, but I think it makes us special. And really that population, to some extent, I think has been overlooked over the last many years. It's nice to know that we have experts that are willing to treat those athletes. So as we mentioned today, I'll be speaking on how we take a holistic approach to the treatment of stress fractures in athletes. And slides aren't advancing. Try this again. Okay, I have no disclosures to make on this topic. I do receive some textbook royalties on a related topic on this the treatment of stress fractures in athletes, but nothing related to this talk directly. I'll be speaking on several aspects of stress fractures from a 30,000 foot perspective, and then from the weeds and the lower perspective as well on directly treating these injuries. So we know that there's a global economic impact to stress fractures. There's an individual impact to it. You're going to hear the word risk mentioned in my talk several times in a lot of different facets with regard to high-risk sites, high-risk sports, and just general risk factors for stress fractures. We'll talk about the evaluation and risk stratification, go through some of the holistic treatment strategies, and I'm going to mention a couple of case examples at the end of the talk if we have time. So Hippocrates was probably the original sports medicine specialist, along with Herodotus, who were from the mid third century BC in ancient Greece. I'm going to mention several quotes from Hippocrates during my talk today. Sport is a preserver of health, as Hippocrates told us. I agree with that 100%. So we want to maintain participation and performance if at all possible in these athletes. As I mentioned, there is a global economic effect of stress fractures overall. We know the pandemic right now with COVID-19 is what gets most of our attention, but I would argue that there is actually a global epidemic of stress fractures in athletes. That's threefold, really, the economic effect that is. So number one, being the cost of evaluation and treatment of stress injuries. It can be relatively high. Number two, the time lost from military service, as Dr. Hutchinson mentioned. And then there's limited team or club success brought on when athletes can't participate for their teams. That can be a major problem economically. The studies you see here are regarding the military. So this study from 2016 in the military medicine was a longitudinal study from 2009 to 2012 that identified nearly 32,000 lower extremity stress fractures among U.S. military personnel. It was found that there was a bimodal distribution of where these injuries took place or who these injuries occurred within. Those under age 20, typically the first-time military recruits going through boot camps, and those over 40 who were the more experienced military personnel who only had to go through PT or fit training a couple of times a year. Females had the highest risk of injury, with nearly 80% of these injuries occurring in junior enlisted military recruits in the Army and Marines. Some of the best studies on stress fractures in military populations have come from the Israeli populations over the last 15 to 20 years. This study from Bone in 2017 was a more longitudinal study from 1983 to 2015 that showed in elite Israeli infantry training programs, meaning essentially military special forces in Israel, there was a 40% incidence in stress fractures in that population back in 1983 when this study first started. However, as late as 2015, when the study ended and was updated, there was still nearly a third of all personnel developing stress fractures and were unable to return to military service after this diagnosis. Multivariate analysis in this group really showed there wasn't much you could do about this. There weren't too many interventions that really made a difference for decreasing this rate. Other than restricting training and monitoring for symptoms, those were the only two factors that could decrease the incidence. What about in professional athletes? This study from Sports Health in 2018 was a study that identified 76 lower extremity stress fractures in 75 NBA players between 2005 and 2015. Over 80% occurred during the regular season. It's a long regular season in the NBA. We're talking anywhere from October all the way into May, and sometimes even longer if they go deep into the playoffs. 14 of these 76 athletes developed stress fractures in the fifth metatarsal, and 6 of those 14 were unable to return to playing professional sports. Surprisingly, of the returners, they had a decrease in games played and a surprisingly overall decrease in statistical productivity when they were playing. Surgery improved their overall rate of returning to sports, but didn't improve their overall statistical productivity. So this is a major concern for professional athletes. What about professional soccer players? This study from the Scandinavian literature from 2012 identified nearly 2,400 athletes with professional European soccer players from 2001 to 2009 who developed stress fractures, with the rate being 1 every 3rd season. So essentially 1 lower extremity stress fracture could be expected every 3rd season in starting players in professional European soccer. Nearly a third of those were recurrent injuries, and the typical time to return took quite a bit longer than what we've seen in other studies, typically 3 to 5 months, as opposed to about the 3-month point for most collegiate athletes that we see in other studies. Individual impact can be significant. We know that there's a loss of playing time, which can then lead to scholarship opportunities being reduced and professional contract opportunities being taken away. Shortened careers can be a major concern for these individual athletes. And as Dr. Hutchinson mentioned, catastrophic injury is a major concern, sometimes even showing up in high-profile cases such as the NCAA tournament back in 2012, this athlete from the University of Louisville who developed an open fracture related to a tibial stress fracture that had taken place that showed up during the NCAA tournament. Around the world, we know that stress fractures are extremely common and they're increasingly common. And particularly in the elite and professional athletes, they're increasingly common and very heterogeneous. It's very difficult to categorize these injuries and stratify them into treatment groups. We've attempted it, we've had some success with that, but we know that they're so heterogeneous that it's hard to label all stress fractures as being treated the same way. 10% of all sports injuries in the World Journal of Orthopedics in 2017 were found to be stress injuries of bone, with an increasing role needed for surgical treatment to decrease the time to return to sport. Among athletes with these injuries, surgery did increase the rate of return to sport by about 25%, but overall surgery is being required much more commonly over the last several years, particularly for the professional and elite athlete. Among American high school athletes, this study from 2015 in American Journal of Sports Medicine that you see here on the left showed that up to 20% of injuries seen in sports medicine clinics in the US between 2005 and 2013 was a bony stress injury. There was a rate as high as over 10 stress injuries or stress fractures per 100,000 athlete exposures in high school sports, with nearly 2/3 of those athletes requiring at least 3 weeks away from sport and medical disqualification. In other words, they couldn't come back to the season because the season ended before they could return to sport. The study you see on the right was of NCAA athletes from the Journal of Athletic Training in 2017, identifying 671 stress fractures being reported in the NCAA between 2004 and 2014. I would argue that that number is woefully underreported. I'll explain why in just a moment. But what was found in that same study was that the highest rates of injuries were stress fractures in female athletes in cross country, track and field, and gymnastics. There was a recurrence rate over 20% in these athletes and a season end rate of over 20% as well. Why do I think that number was woefully underreported? Well, this study done right here at Ohio State and published in Sports Health in 2018 from our group was a study of the Ohio State track and cross country teams alone. This study identified from 2011 to 2014, 57 stress fractures diagnosed in 37 Division I collegiate track athletes from Ohio State. 10 athletes sustained recurrent or multiple stress fractures, the majority being women, the majority of those being in the tibia, though there were 10 metatarsal stress fractures and a surprisingly high rate of pelvic stress fractures. There were 5 of them of those 57. The mean time to return to unrestricted activity took just around 3 months, plus or minus a month or so a little bit faster than what the professional soccer players did. But nonetheless, it takes quite a while for these athletes to return. So going back to the wisdom that I mentioned from Hippocrates in his dissertation on fractures, he said the greatest champions do not ruin their seasons with injury by training too hard too early. Got to keep in mind that we have to address training and technique, not just treat the injuries as a reactive measure after the injury has taken place. So there are several biomechanical risk factors that can be identified, some of which were mentioned by Dr. Hutchinson, that can contribute to the risk of a stress injury. Musculoskeletal weakness, or what we refer to as the neuromuscular hypothesis, where muscles, when they fatigue or are just plain weak, will sometimes lead to increased ground reaction forces being dissipated not into the soft tissues, but directly into the bones, increasing the risk of stress injury. Overtraining syndrome, simply just doing too much training too quickly. Equipment and footwear, as Dr. Hutchinson mentioned, can be a big factor. And what doesn't get mentioned a lot, but should be probably more mentioned, is the single sport specialization of athletes. This has become much more popular over the last 10 to 15 years, increasing the risk of overuse injuries, particularly stress fractures. So why do overuse injuries take place? This quote from American Family Physician in 2007 summed it up really very well. An imbalance caused by overly intensive training and inadequate recovery leads to a breakdown in tissue, reparative mechanisms, and eventually to overuse injuries. And this certainly occurs not only in soft tissues, but definitely in bone. So biomechanical risk factors have been identified specifically for tibial injuries. We know that a higher body fat percentage by approximately 3% increases the risk of tibial stress fracture. A lower lean muscle mass percentage, 3% increases the risk of stress fracture in the tibia as well. Not surprisingly, low bone mineral density increases the risk of stress injury. And when we do DEXA scans, we know that we typically identify 3 different areas to determine where bone density is being measured, that being the spine, the distal radius, and the proximal femur. What has been found in this population is that lower bone mineral density at the proximal femur increases the risk of tibial stress fracture. Fatigued thigh muscles, as we mentioned with regard to the neuromuscular hypothesis, increases strains up to 3% within the tibia, and decreased tibial cortical width, not surprisingly, thinner bones in general are more predisposed to injury. Higher rates of foot anomalies, as mentioned in part by Dr. Hutchinson there a moment ago, increase your risk of injury, with cable varus foot deformity being identified as one particular risk. This study from 2019 was of over 1,000 initially healthy Royal Marine recruits in Britain, followed through basic training, a 6-month period. They identified 7 second metatarsal stress fractures and 14 third metatarsal stress fractures in this group alone. Cable varus foot deformity was identified as the greatest risk factor for a second metatarsal stress fracture in age under 20 years old. Again, that initial basic training recruit has an increased risk of stress injury. So I mentioned single sport specialization, defined by Rob Laprade et al. Back in 2016 in American Journal of Sports Medicine. Single sport specialization really boils down to intensive year-round training in a single sport to the exclusion of other sports. And for the pediatric population between 7 and 18 years of age, 3 years of focus on one sport was an independent risk factor for overuse injuries, with the most common being a stress fracture. We know that this is likely overlooked and probably underreported as well, because a lot of these injuries are simply chalked up by parents and coaches as growing pains or normal wear and tear from injury, and they don't get a full workup. So they probably are occurring much more commonly than we really think. It's important to remember that stress fractures don't just occur in the lower extremity. The study done by our group back in 2012 and published in Sports Medicine was identifying the stress fractures that occur in the upper extremities and the ribs. We found that though they were much less common than the lower extremity, in fact, less than 10% of stress injuries occur in the upper extremities and ribs, they still occur in certain populations. They occur anywhere from the sternum all the way out to the phalanges of the fingers. They're most commonly seen in endurance athletes, throwers, and military recruits. They result from fatigue and overuse of the surrounding musculature, not surprisingly, and they are at a higher risk with poor pre-training conditioning that predisposes these athletes and military personnel to this injury. There are 6 categories that we've placed these athletes into when they have upper extremity stress fractures, those being upper extremity weight bearers. So that includes, for example, gymnasts, cheerleaders, divers, or other athletes who spend a lot of time bearing weight on their upper extremity. That includes the military population that does a lot of push-ups, for example. Rowers or crew team members have a higher propensity to develop rib stress fractures, particularly those of the lower ribs, typically anywhere from the 5th to the 12th rib. Overhand throwers, including baseball pitchers, javelin throwers, or quarterbacks, have an increased risk of stress fracture around the shoulder girdle. Axial rotators, which we define basically as athletes including golfers and tennis players, as well as discus throwers on the track team, that continually repetitively rotate their torso, again have an increased risk of stress fracture of the lower ribs. Weightlifters in our group of 70 that we identified over a 10-year period occurred really by the broadest spectrum, anywhere from the sternum through the clavicle, all the way out to the scaphoid at the wrist. The miscellaneous group include underhanded throwers in general, as well as climbing athletes that develop stress fractures quite commonly in the phalanges of the fingers in the climbers. So Dr. Hutchinson mentioned the idea of relative energy deficiency in sport contributing to stress injury. Absolutely, that's true. There are multiple nutritional risk factors for stress fractures. We know that REDS is one. That's more or less overtaken the terminology of the female athletic triad, though we still use both terminologies. The nice thing about REDS is that it applies to both male and female athletes. Vitamin D insufficiency, you can't really discuss treatment of stress fractures these days without mentioning the importance of vitamin D and its effect on bone homeostasis. Malabsorption disorders we commonly forget about in elite level athletes, but that can occur. Certainly celiac disease, Crohn's disease, other disorders of the gut can make a difference as far as getting those nutrients into the body and storing those bones with the appropriate nutrients that they need. Low BMI, we found in multiple studies that a BMI of 19 or less increases the risk of stress injury and increases the time to return to sport. We'll talk about that more in just a moment. So going back to the wisdom of Hippocrates, again, it's amazing how important and how perceptive he was even 2,500 years ago. So let food be thy medicine and medicine be thy food. You want to optimize nutritional and hormonal status in these athletes to help prevent these injuries and optimize their healing potential. So we know, as we mentioned, that low EA or low energy availability increases the markers of bone resorption and decreases the markers of bone formation in physically active women in particular. The effect of long-term low energy availability decreases bone density and decreases bone strength. It certainly increases the risk of stress injury. With regard to vitamin D, the study on the right from the Journal of the Army Medical Corps from 2018 showed among 37 British Army recruits who were diagnosed with a stress fracture during basic training was found that a serum vitamin D level, or 25-hydroxy vitamin D of greater than 20, which is considered above the insufficient range, or basically in the pseudo-normal range, did not prevent development of stress fractures. We typically would recommend at least over 30, ideally around 45 to 50, rather than anything over 20. It was also found that recruits with a serum hydroxy vitamin D of less than 20 took significantly longer to heal and return to military duty. The study done right here at OSU and published in 2017 in Current Orthopedic Practice. We'll talk about the Kading-Miller classification system in just a moment, but it's not surprising that the higher level of severity on our scale increases the length of returning to sport. The more severe the injury, the longer it takes to return. And again, in the same study, we found that BMI of 19 or less took athletes longer time to recur, and they had a higher rate of multiple stress fractures occurring when they had a BMI of 19 or less. So talking about the risk of behavioral health concerns or psychological impact of stress fractures. So as Hippocrates told us, if you're in a bad mood, go for a walk. If you're still in a bad mood, go for another walk. And you want to treat both physical and emotional concerns of athletes with stress injuries, because we know that a lot of athletes and just the general population will use exercise as a release for their stress. That's not a bad thing necessarily, unless it gets overdone. So the psychological risk factors for stress injuries, exercise addiction, or just being essentially addicted to that runner's high. Again, exercise is a good stress release, but when you do it too much, it's going to potentially put you at risk of injury. The female athlete triad, we'll talk about in just a moment, with the risk of disordered eating, and sleep deprivation, which we commonly overlook as well. We know from our presentation from Dr. Chad Asplund a couple of years ago, right here at our symposium, that many athletes, particularly Division I collegiate athletes, get less on average than 6 hours of sleep per night, and that's on average about 2/3 of Division I athletes who are relatively sleep deprived. So with regard to the female athlete triad, the consensus statement from the 2014 group stated that what it's really defined as is, number one, low energy availability with or without disordered eating. So you don't have to have anorexia to be considered part of the female athletic triad. Menstrual dysfunction, not just complete amenorrhea, but menstrual dysfunction in general, and then low bone mineral density. Indications for a DEXA scan or bone mineral density evaluation are several. History of an eating disorder, a BMI they defined as less than or equal to 17.5. I would argue that 19 or less should be that number. Men are at 16 or older. Current or history of less than 6 menses over a 1-year period, and 2 or more prior stress reactions or stress fractures definitely indicate the need for bone density studies, as well as serum testing for other risk factors for stress injuries. How do these athletes present? Typically, the history is going to be of increased training intensity and or frequency or volume over a relatively short period of time. So relatively poor training that increases too quickly. Increased pain with athletic participation eventually, it starts with athletic participation, but eventually affects activities of daily living. Irregular menses we mentioned, and certainly a history of a prior stress fractures can increase your risk of injury over time. What are the high-risk sports? Again, we mentioned these words of risk multiple times during this talk. This study from Adam Tenford and AJSM in 2017 described 239 female Division I collegiate athletes who developed stress fractures. The highest risk sports in that group being gymnastics, lacrosse, and cross country. Moderate risk sports included track and field, and it was shown that they were twice as likely as low-risk sports such as swimming to develop an injury. And high-risk athletes or high-risk sports were nearly 4 times as likely to develop a stress injury. Independent risk factors for these sports being for developing stress injuries of bone, being oligomenorrhea or amenorrhea, and prior history of a stress fracture or stress reaction. So evaluating and risk stratifying these injuries. That's very important for determining how we can potentially help to prevent these injuries. Body composition assessment has been the next step beyond bone density assessment. So an IDEXA, which we use quite commonly and have been using that over the last 10 years, IDEXA stands for Intelligent DEXA, measuring our lean and non-lean soft tissue mass ratios to determine if we have an area of weakness, particularly of that proximal femur or other areas of the lower extremity, that we can potentially strengthen with our strength and conditioning coaches that can eventually decrease those ground reaction forces being dissipated into the bones. Serum lab testing, very important, particularly when there's been multiple stress injuries or multiple other risk factors involved with this. We know that there are essentially two groups or two types of or categories of serum lab testing that we recommend. One is nutritional labs. Certainly vitamin D is the one we use most commonly these days, or rely on the most, but it's important not to overlook the importance of evaluating hormonal status. So hormonal and nutritional evaluation is really what we do with our lab testing, and that's very important. Again, high risk versus low risk, and that really describes the sites. A high-risk stress fracture is one that typically occurs in an area of high tensile forces. Again, when there's tension or bending forces taking place across an area, those osteoblasts have to work harder to cross that area, making it difficult to heal and leading to a higher risk of propagation. The other component of high risk is relative avascularity. Some sites have both hypovascularity and tensile forces acting upon them. That's what really defines them as high risk. So if you learn nothing else from this talk today, what I would tell you is to learn what's on this slide, particularly what's on the bottom left, the high-risk sites. It's important to remember that not all high-risk stress fractures occur in the lower extremity. The olecranon and the scaphoid occur in the upper extremity. Those are considered high risk. And then tension side of the femoral neck, the anterior aspect of the patella, the anterior tibial diaphysis, the medial the talus, navicular, the proximal fifth metatarsal, and the great toe sesamoids. We'll go through a few of those in more detail to highlight why, but if you learn nothing else, know that box right there. Describing stress fractures and categorizing them as far as more or less risk stratifying them and categorizing them into treatment groups has been done by myself and Dr. Kading since we published our study with our classification system in JBJS in 2013. I'm not going to go through the whole thing, but it's important to remember that the more severe they are on this spectrum, the longer it's going to take to recover. A grade 2 is what we see most commonly. That's an athlete with symptoms of stress fractures or pain with imaging evidence of bone stress injury, but not necessarily a full-on fracture line. That works its way all the way up to the most severe being a non-union. So we use this classification system to determine our treatment strategies. So initially, we optimize the patient's nutritional, hormonal, and psychological status. Once these athletes have been categorized with the severity of their injury, which is usually going to be a grade 2, quite commonly a high-risk grade 2, those respond to the same treatment as a low-risk grade 3, or complete rest, typically for 6 weeks. And if we don't see significant healing or clinical improvement, not uncommonly, they will require surgery. Anything higher than a high-risk grade 3, they're going to require surgery most likely for stabilization or complete removal of the bone, as is the case for sesamoid stress fractures. So let's talk about a few of the highest risk sites. So again, why are they high risk? The femoral neck, the tension side of the femoral neck, or the proximal aspect of the femoral neck, has a retrograde blood supply from the medial femoral circumflex artery. If it gets cut off, then there's a risk of AVN of the femoral head. Additionally, the cantilever effect of weight bearing through the pelvis, through the femoral head, puts a tension force across that superior neck, leading to a high risk of propagation of this injury. Vertical shear forces, again, the higher the angle or the more vertical the angle of the fracture, the higher risk there is of displacement of the injury. These typically present with deep hip or groin pain, pain with single leg stance or hop tests. These require strict non-weight bearing and aggressive treatment, usually surgery. Open reduction turn of fixation, as you see here on the right, typically with 3 parallel screws or a compression plate or compression screw, decreases the risk of morbidity of a complete fracture, including non-union, AVN, and decreases the time to return to sport, although it can still take a long time with this injury, typically about 6 months to return to sport after a femoral neck stress fracture. The anterior cortex of the tibia, sometimes referred to as the dreaded black line. Thankfully, it's less common than the posterior medial cortex stress fractures, which heal much more readily. The anterior cortex makes up about 5 to 15% of tibial stress fractures. It's under tension, brought on by the pull posteriorly of the calf muscle. They have a high potential for complete fracture, delayed union, and the return to sport takes a long time. Even with surgery, it takes usually 10 plus weeks. Without surgery, it takes up to 6 months. Let me just highlight here, even though it may not show up that well on these images, hopefully you can see that. This athlete, who's a professional soccer player, has multiple stress injuries, tiger striping his entire anterior cortex of the tibia. You can see the anterior cortex is a little bit thickened, but there are multiple stress injuries of varying levels of severity and various points in healing all across the anterior cortex. He had low vitamin D upon serum testing and also had to undergo intramedullary rod fixation to treat this for the long term. And The dreaded black line can lead to a catastrophic injury if not treated, so don't neglect this type of injury. What they usually present with on one of your sideline physical exam, pain on palpation, typically at the central third of the junction of the middle and distal thirds of the tibia. Fulcrum test, which you see here on the top right, is more or less creating a 3-point bending force either across your forearm or across the end of the table. Pain with a single leg hop test or single leg stance. Tuning fork test I use intermittently. I don't necessarily rely on that because it's a relatively low sensitivity and specificity, but you'll see it described in a lot of the literature as a way to identify these injuries in the training room, but don't rely on it solely. Treatment options, again, takes a long time to recover from this. 3 to 6 months of rest and protected weight bearing if just immobilization and non-surgical treatment is used. We will employ electrical stimulation or bone simulators fairly commonly for these injuries because they have been shown to have some promise, particularly with the delayed union in the tibia. Intermedullary rod fixation we use very commonly for these, particularly when there are multiple stress fractures involved. Tension band or compression plating has been popular as well. There are some risk factors with that, meaning that the hardware commonly has to be removed. And then excision of the area of bone and bone grafting is sometimes required, but the consensus being for a competitive athlete relatively early in the treatment for a chronic anterior cortex stress fracture, an intramedullary rod or a compression plate to speed healing. Navicular stress fracture, kind of a double whammy, sort of like what the ephemeral neck tension side is. The dorsal cortex is a region of relative hypovascularity, so poor blood supply to the area. There are also tensile forces created by compressive forces taking place both medially and laterally with sprinting. So it creates a zone of maximal tensile force at the central third of the dorsal navicular. Fractures occur typically in a sagittal plane, splitting straight down through that central portion of the navicular from dorsal to plantar. These injuries typically present as vague dorsal or medial midfoot pain that's worsened with running or jumping. They have tenderness at the end spot, as we call it, the space in the dorsal medial cortex of the navicular between the extensor hallucis longus tendon and the anterior tibialis tendon. They present typically with a positive hop test or pain with single leg stance or single leg heel raise. These can be treated non-operatively, but again, it takes a long time, and usually high-level athletes aren't willing to wait 5 months in order to heal, but a cast and immobilization can be attempted. Surgical treatment with early open reduction internal fixation is commonly required for elite level athletes to prevent displacement and long-term disability. Return to sport, though, even with surgical fixation, can take up to about 4 months to get back to full activity. Fifth metatarsal, sometimes referred to as the Jones fracture, commonly presents as an acute event with a prodrome of vague lateral foot pain leading up to that for several weeks. The sideline physical exam typically is going to show point tenderness across the proximal metaphysis of the fifth metatarsal, localized swelling, and pain worsened with ankle inversion or the single leg heel raise. See here on x-ray, you don't always see this right away. Again, if you're still in that prodromal phase of just increasing stress, you won't typically see that actual fracture line coming through there. Once you do, it can take a long time to heal and typically requires aggressive treatment. Why is this? Again, the double whammy that I mentioned, a single intramedullary arterial supply, it's retrograde. So if you get a fracture through that zone 2 area of the proximal metaphysis, you lose that blood supply to the distal portion of the metaphysis, distal portion of the proximal metaphysis, leading to delayed healing. The plantar lateral cortex is also under tension. So again, that's the second portion of the double whammy. Fixation decreases the risk of delayed union, non-union, and refracture. Even though it decreases that risk, it doesn't eliminate it. For the surgeons out there, you want to make sure you use at least a 4.5 millimeter diameter screw, preferably a solid screw, not a cannulated screw. You want to confirm complete healing on x-ray and or a CT scan before returning an athlete to play. And even with that, with non-operative treatment, there's a 7% non-union rate and nearly 18% refracture rate. With surgery, there's a lower rate of non-union, but still relatively high at nearly 5%, and a nearly 7% refracture rate, as you see with this athlete. This was a professional football player from the San Diego Chargers I treated a few years ago. He refractured twice. The first fixation was done by an outside physician, was never completely healed when he returned to play, broke it again. We took his hardware out, bone grafted him. He did eventually heal within about 9 weeks the second time around, but about 6 weeks later, returning to professional football, he broke again and required a third surgery. So it can take a long time to heal, and you're never really guaranteed that they're done healing. So again, the wisdom of Hippocrates really knows no bounds. So in his statement, illnesses do not come upon us out of the blue. They are developed from small daily sins against nature, and when enough sins have accumulated, illnesses will suddenly appear. You want to maximize the healing potential and rest the bone if at all possible to prevent this. So it takes a very diverse treatment group, as Dr. Hutchinson was mentioning, in order to treat athletes, not just for stress fractures, but for endurance sports in general and for overuse injuries. You want to stop or limit the cause of activity. That's typically going to be done by your trainer. Protect the weight bearing that's done by the orthopedic surgeon or even the surgical component of it. Nutritional optimization by your nutritionist is extremely important. Mental skills training from your sports psychologist. Hormonal imbalance to be performed by your endocrinologist and your primary care physician. And biomechanical optimization done by our physical therapy colleagues. Alternative training can be offered by the coaching staff, though the clinical staff want to be aware of this as well. Quite commonly, we'll use the aquatic treadmill, which you're seeing here on the top right. That's not always available for the off-the-street athlete or the standard recreational athlete. For our elite level athletes, can be very helpful, as is the Alter G treadmill, as you see here on the bottom right, to decrease those ground reaction forces and allow the biomechanics to be retained with running. Prescribed sleep, again, very important. Again, probably overlooked among elite level athletes. Prescribed sleep is extremely important to promote the healing of these injuries. This algorithm that Dr. Keating and Scott Rodeo and I published in JAOS in 2020 really sums up the spectrum of treating stress fractures overall. Again, you want to optimize those biomechanics, mental health, and loading exposures to these areas of injury. You want to assess their nutritional and hormonal status with the laboratory testing we mentioned. Then once they're optimized, you want to treat them aggressively if you have to, particularly at the high-risk sites. You want to consider surgical stabilization with internal fixation, plus or minus biological augmentation of bone grafting. And when you still have trouble healing, you want to consider these newer biologic treatments to simulate this healing. We'll talk about these in a little more detail. So direct injectable modalities have become much more popular over the last 5 to 10 years. These include concentrated bone marrow aspirate, otherwise known as BMAC. It can be harvested from the calcaneus, the proximal tibia, or most commonly from the iliac crest. Iliac crest has been shown to produce the highest number, the highest rate of active cells. We can not only just inject that directly, but we can also inject it mixed with that third point you see here, the injectable bone graft substitutes like the mineralized bone matrix. PRP or other autologous plate-rich technologies can be used in combination with the bone graft substitutes as well. They're rarely employed just as a direct injectable treatment for a stress fracture, but people are experimenting with this without a whole lot of scientific evidence to prove it does a whole lot. Subchondral calcium phosphate injection, as you're seeing on the bottom right, called a subchondroplasty, can increase the density of bone in those areas, in the most metaphyseal regions of bone. That's usually a little bit more common for insufficiency fractures rather than for stress fractures, but there is some use and some utility for stress fractures too. The indirect stimulating agents, including pulsed parathyroid hormone, is becoming much more popular with some professional athletes. I would not recommend doing this individually if you're not trained to do this. I would definitely have your endocrinologist do this for you, or at least make sure it's a team approach when you do this. Forteo or teriparatide, otherwise known as parathyroid hormone, simulating some bone resorption can actually stimulate some bone healing too, if it's done properly. Additionally, electrical osteostimulation with bone simulators, as you see here on the bottom left, that being with either pulsed electromagnetic field or low intensity pulsed ultrasound, can be helpful in the, more likely in the delayed union setting, or sometimes simply as a psychological component to make sure your athletes know that you're doing everything you possibly can to improve their healing rate. Extracorporeal shockwave therapy or shockwave treatment has come and gone and come and gone and come and gone and come and gone many times over the last several years. It's still used today as the mechanotransduction that's brought on by shockwave therapy can simulate osteoblastic activity in an area of a fracture and potentially increase the rate of development of callus across the area, stimulating healing. Every once in a while, though, as an orthopedic surgeon, you got to remember that we are surgeons in general, or I am, and Dr. Hutchinson is, and you got to use what my former chairman would refer to as the tincture of cold steel. So plates and screws can help. Sometimes an intramedullary rod can help as well. Open reduction internal fixation without bone grafting in most severe cases is commonly required. Intramedullary fixation, as I mentioned, and then bone excision in the case of sesamoid stress fractures. So, returning to Hippocrates, the greatest medicine of all is teaching people how to not need it. So we want to prevent stress fractures first and foremost, if at all possible. Is that even possible though? You know, when I first started into practice, I thought I was going to figure out a way over my career to stop stress fractures from happening. I don't necessarily think that's possible. I have over times gone back thinking that I could, but I think in general, when you prevent one stress fracture, you're actually allowing an athlete to train even harder potentially and eventually develop in further injury in some other way or with more intense training. So we may not be able to ever completely stop overuse injuries or stress fractures from occurring, but we can at least decrease their rate likely. Training periodization, I mentioned that before, as far as making sure that we don't train too hard too early or too intensely too quickly. Caloric support, maintaining that proper energy availability for these high-level athletes. It's going to be somewhere between 4,000 and 6,000 calories per day for endurance athletes. Form or running gait analysis, you're going to hear about later on today, as far as how important it is to optimize their biomechanical status. Resistance training commonly gets overlooked with endurance athletes. They think, well, I'm just a runner. I don't need to be strong. I don't need to bulk up. And while I agree that bulking up is not required, maintaining resistance training to maintain that strength and decrease fatiguing is going to help to dissipate those ground reaction forces in the lower extremity and the upper extremity with rotational forces from throwing. Adequate rest and recovery, minimum 8 hours per night for the elite level athlete training hard, particularly with those collegiate athletes and higher. Off seasons, what are those? Those really don't exist anymore. Basically, for high level athletes, there's no off season. It's really just a non-competitive or less competitive season, but making sure that they take advantage of those and decrease their intensity during that time is important for preventing long-term injury and long-term time to recover. So a couple of stress fracture cases just to highlight this and bring it all together. This is a 20-year-old female Division I collegiate middle distance runner. She reported worsening left dorsal midfoot pain for about a month. She denied any trauma to the area. She had pain initially only with running, but now with activities of daily living. That was worsening more and more. She had her training intensity had increased significantly leading up to the indoor track season. She reported using ibuprofen and orthotics that helped initially, but continued to have pain, and was now using anti-inflammatories multiple times a day with really minimal improvement. She had a history of one prior tibial stress fracture. She initially went through x-rays which were negative of her ankle and foot, but then she was treated with partial weight bearing in a cam boot for 3 weeks, but did not improve. Eventually, she underwent an MRI that you see here on the right. This is a sagittal T2 MRI showing, if you look closely, I'll highlight it, one bone looks very different from the rest. That's the navicular, and that's where she developed a stress fracture. Diagnosed navicular stress fracture in the area, even though it shows the entire bone lighting up, it was mostly on the dorsal cortex. Given her history of multiple stress injuries, she underwent lab testing. She had serum vitamin D that was relatively low. It did not reach the insufficiency range, but still was borderline to it, or very close. So certainly under 30, was not under 20, but definitely relatively low. She was started on a vitamin D3 supplementation, made non-weight bearing, and then a CT scan was performed that you see here on the right, showing a Saxena grade 2 or a Kading-Miller grade 3 stress fracture of the dorsal navicular. So given the relative chronicity and high risk of this site, surgical fixation was recommended. She underwent fracture drilling as well as open reduction internal fixation with cannulated screws, compressing the fracture, along with concentrated bone marrow aspirate, firmer calcaneus into the fracture site. She was asymptomatic and non-tender by 4 weeks out from surgery. She was allowed progressive weight bearing at 6 weeks post-surgery. And her radiographs, even though they showed around that same time complete healing, there was also some some disuse osteopenia was brought on that we had to account for. She returned to training at 8 weeks post-surgery with no setbacks. And she was continued on a vitamin D3, not only through that year, but also through the subsequent indoor track season that she did participate in. Case number 2, semi-professional football player, 25 years old. He's a wide receiver. He presented with lateral foot pain and swelling over a 1-month period. He denied any direct trauma, but reported worsening pain not only for the month, but then felt a pop during a game and could not continue. He underwent radiographs to evaluate it. This radiograph shown here, I'll highlight them a little bit, showed a non-displaced proximal 5th metatarsal metadiaphyseal fracture. You can see some lateral cortical thickening going on there, indicative of that chronic phase that was taking place there, and the acute fracture, making this a Kading-Miller grade 3. Given the chronicity again and the high-risk nature of this injury, surgical stabilization was recommended for him. He underwent intramedullary screw fixation with a solid screw, augmented with calcaneal bone marrow aspirate, as you're seeing here. We're harvesting it, and we concentrate that, then inject it back into the site. He was kept non-weight bearing for 5 weeks and supplemented on calcium and vitamin D3 during that time. There's is the screw. You can see us injecting right into the fracture site. We inject not only into the site, but actually down the canal before we place the screw. This is us injecting percutaneously after the screw has been placed. And at 5 weeks post-surgery, this athlete was pain-free and non-tender to the fracture site, and his radiographs indicated they did have complete radiographic healing. So 5 weeks is pretty fast for any high-risk stress fracture to heal. But with these added adjuncts, he was able to completely heal it along with that screw to assist the compression. He underwent progressive weight bearing and returned to training at 7 weeks and had no setbacks and was able to return to football the following year. Those were his final x-rays there. So summing it all up, not all stress fractures are equal. We know that. High risk versus low risk, you have to know the difference. You want to use a holistic approach with a diverse treatment team to get the optimal recovery and minimize the time away from sport. You want to optimize them biomechanically, nutritionally, hormonally, and psychologically to get the best outcomes. Surgical stabilization and biological augmentation may be necessary for athletes requiring minimal time away from training. And above all, know the high-risk sites, the ones that were in that box I showed you earlier on in the talk, are the keys to know who to refer and how soon to refer them. They require the most aggressive treatment. Not always surgery, but the most aggressive treatment nonetheless. And finally, from Hippocrates, if we could give every individual the right amount of nourishment and exercise, not too little and not too much, we would have found the safest way to bone health. And I would say amen to that. Thank you for your attention.
Thank you, Dr. Miller. That was fantastic information. We will go into some poll questions regarding Dr. Miller's talk next. So we'll pause a moment to get those pulled up. Question number 1, which of the following is considered a high-risk site for stress fracture progression? Go ahead and click the best answer and click submit. The majority has it. The correct answer is A, dorsal navicular. Question number 2. We'll wait a moment for that second question. Which of the following is a risk factor for propagation of a stress fracture? A, antegrade blood supply. B, compressive forces. C, serum vitamin D greater than 45. Or D, tensile forces. This one is a more challenging one, but you guys got it. Correct answer is D, tensile forces. Thank you, Dr. Miller. Our next speaker is Dr. William Kelton Vasileff, an orthopedic surgery specialist at The Ohio State University Wexner Medical Center that specializes in sports medicine and hip preservation. He graduated with honors from The Ohio State University College of Medicine in 2008. Dr. Vasileff did a residency and sports medicine fellowship at Henry Ford Health System in Detroit and a sports and hip preservation fellowship at University Hospitals in Cleveland. He has more than 13 years of diverse experience in orthopedic surgery, and he has been an Ohio State College of Medicine faculty member since August 2015. Dr. Vasileff has been rated in the top 10% of physicians in the nation for patient satisfaction twice and has helped care for many athletes, including the Detroit Lions, the Cleveland Browns, Lawrence Tech University teams, and multiple high school teams. He is the co-lead for sports orthobiologics at Ohio State. Please join me in welcoming Dr. Vasileff.
obviously, please let me know.
Dr. Vasileff, we're having a hard time hearing you. If you could speak up or turn your volume up, that would be helpful.
Can you hear me at all, or just is it quiet?
It's very quiet.
Is that doing any better, or no? Is it not the same?
That's much better.
Is it? Okay, gosh, I thought I had the microphone set to my webcam, but apparently not. So, all right, so here we go. So here are my disclosures. I do a little bit of educational work with a couple of our medical device companies here. We're going to talk a little bit, focus a lot on hip pathology today. Obviously, I focus a lot on my clinical care, academic research, educational work on hip pathology. There's a few things that I think will overlap a little bit with some of our prior discussions, some of the stress fracture things, as well as just a little bit with Dr. Berria's discussion about the some of the orthobiologics as well. But here we go. So brief discussion about the epidemiology here. So hip injuries in general account for about 6% of sports injuries, 3% of NFL injuries. Hip flexor strains, obviously very common. Intra-articular hip injuries, 10% of NHL athletes, and 14% of the injuries in the NBA over 24 seasons, if there was a large survey that they did there. And then in terms of other sports related injuries, muscle contusions, strains, and lacerations, around the hip, significant cause of lost time and injury in that population as well. So if we're going to focus kind of mostly, obviously, with some of these endurance athletes, mostly on cycling, swimming, and running here. So to talk about cycling just a little bit, a few things, just to think about. Fit and form is very important. Retropatellar knee pain, most common kind of chronic knee issue in the cycling athletes. Patellofemoral malalignment, muscle imbalances are the most common root causes, though. Pes, anserine bursitis, and tendinitis, as well as medial plicas, can be one of the biggest causes of medial knee pain. IT band pain at the knee is most common lateral knee pain. And then the hip, greater choke pain syndrome, which we're going to talk about in significantly more detail later, as well as iliopsoas tendinitis, are the most common hip issues. And some of our cycling endurance med, the physical therapists will tell us again, the hip, the fit and form is very important, and then a lot of these things sometimes stem from malpositioned seats and stems and things like that too. And there's also a lot of crossover here, as there is in other back, hip issues, low back, pelvic pain, and a relative lack of mobility that causes some maladaptive movement patterns. So swimming, 20% of high-level swimmers reported some kind of musculoskeletal pain at a big meet that there was a survey done. 60% reported a prior injury. Shoulder is obviously the most common. Low back pain was number 2. If they looked at current versus prior injuries, knee was the most common prior injury that they had, and tendinopathy was the most commonly reported issue in this population as well. Most of these were training derived and not necessarily related to competitive injuries that they saw. Multiple studies showing 50+% injury rates at 12 months. And in some of these studies, the shoulder is really responsible for 90% of the repulsion and the majority of injuries in swimming athletes. And we'll talk about this again in a little more detail, but the groin pain and adductor pain was present in 41% of breaststrokers, 21% of those doing individual medley, and 6% of other swimmers. So those that are runners, the hip accounts for 5 to 10% of all injuries in the triathletes. Risk factors, hip external rotation, gait pattern, prior injuries, kind of like anything we talked about. Most common risk factor is that it happened before. Those that are doing pretty high volume running, as you see there, greater than 64 kilometers a week, year-round running, narrow tibial
width there, and then a relatively decreased regional muscle strength, which probably also accounts for some of the things that Dr. Miller was talking about with the energy availability. Greater choke pain syndrome, risk factors for these: overloading, overtraining, running on banked roads, those that ran in a track typically in the same direction all the time, downhill, those with the leg length differential, which is kind of like running on a banked road all the time. Cavus foot and varus knees were all risk factors for greater choke pain. IT band pain, which is, I think, closely related, and there's a lot of overlap here, but there are some athletes that I do think are a little bit different in the presentation here. And those are typically more overuse and tightness, and some of that IT band pain, different than the greater choke pain, does extend further down the leg as well, and down towards the knee, like we talked about a little bit, the lateral side of the knee. Stress fractures, in the running athletes, more common. Dr. Miller obviously very well covered this female athlete triad. Femoral stress fractures, as well as pelvic, pubic stress fractures, and sacral stress fractures. Snapping hip is a relatively common thing that we see. Internal snapping hip is what we talk about as the snapping that you can hear, and an external snapping hip is the snapping that you can see, to kind of help differentiate between those things there. So to review the anatomy here, and this is one of the ways that I discuss this with our patients in the office regularly as well. We talk about approaching the hip in layers. The first layer is the osseous layer. We talk about the bony structure, your acetabular structure, orientation, inclination, version, as well as the shape of the acetabulum and the shape of the proximal femur. Some folks are, slightly more varus or valgus in their femoral neck, as well as there can be significant variability. This is something I've appreciated much more in the last few years when we get a lot of our pre-surgical three-dimensional CT scans that include femoral version measurements, that there's a significantly more variety with that femoral version than I think what we, always appreciate clinically. So the second layer we talk about is this capsule and ligaments, and sometimes I'll talk about the cartilage layers in there with patients as well. The cartilage layers that lines your femoral head and acetabulum, the labrum that forms that suction seal, the capsule, and then all the ligaments that surround the hip joint as well. Then this third layer is a myotendinous layer. There's a lot of different muscles that cross your hip joint, stemming, if you start from the inside, you got your abductors, your adductors, then hip flexors, your abductors, your glutes, your hamstrings, and then really, to me, I kind of have started extending this a little bit more to really include your low back musculature, as well as the core muscles in the front as well, because I think a lot of those really things play together as well. And the fourth layer I typically describe to patients as this kind of skin, nerves, and blood vessels, and for most folks not involved. So talking about a hip pain differential here, non-hip pathology, which is obviously not the subject of this talk specifically, but lumbar spine issues, things intrapelvic or intra-abdominally, pelvic girdle pain itself. And then we can have there's a lot of different reasons to have pain coming from the hip joint itself. FAI, femoral acetabular impingement syndrome, dysplasia, labral tears, cartilage injuries, arthritis, insufficiency fractures, slightly different than stress fracture, proper, and then bone marrow lesions as well. And this is just a slide coming from one of this, articles from PM article in 2016, just showing the vast spread of different injuries potentially related to, hip pain and where that can go. So just thinking about how to differentiate between some of these things and narrow in our more common diagnosis can be challenging at times, which reflects, I think, sometimes some of the challenges we have getting patients appropriately diagnosed and treated as well. So this is a presentation, kind of a slide showing just the flow chart treatment of more of these kind of intra-articular hip injuries for athletic and hip groin athletic injuries. And I think this, this gives us a little bit of a good pathway here. Some of these things talk about core muscle injuries here as well, which is kind of right over here. Can you guys see the mouse over here? Sorry, I got two different screens going here. I'm trying to see which one you can see where I'm highlighting here. Do you see the mouse there at all? No mouse. That's what Cat Wayman's telling me. So sorry, I'll keep going here then. And then if we moving this box out of the way here, intra-articular disorders, these are kind of less likely in active endurance athletes, although I think it's something important to consider as well. And then intra-articular disorders, different ages and stages, the youth versus the masters, kind of age range, and you'll see different pathologies at different stages as we go through here, FAI, labrum tears, and that happens. I've treated that, when athletes and endurance athletes from, late teens, high schools, all the way up into their, 50s and 60s occasionally as well. Arthritis obviously is something, and as our athletes age, we have to be a bit more cognizant of. Avascular necrosis, I've seen this, unfortunately, even in some higher level athletes, which, including some pretty active triathletes, which has been, significantly problematic for their, triathlete participation careers. Synovial disorders, as well as autoimmune kind of rheumatoid arthritis type issues that we have as well. So moving over to the anterior hip pain pathology section that we have here too. And then, so talk a little bit about adductor injuries here, athletic pubalgia, osteitis pubis, internal snapping hips, stress fractures. We'll cover briefly. Obviously, Dr. Miller did a really good job with that. Hip flexors and rectus injuries, and then intra-articular pain just a little bit here too. The adductor injuries, which we're going to talk about here first, your adductor, longus, magnus brevis. Then your gracilis, is also one of these, and your sartorius do cross two joints as well, and can be significantly more at risk for injuries just because of that. Your obturator internus and pectineus as well. And there's large mechanical loads placed on some of these small tendons, particularly the adductor longus. These typically occur from eccentric contraction. A lot of these injuries are very common pivoting, cutting activities, soccer athletes, hockey athletes as well. And then swimmers we're going to focus on here a little bit. And as you see in the chart here, swimmers are, particularly breaststrokers, are at very high risk of adductor injuries. And these are athletes that are unable to participate because of groin pain. So this is a high level survey that did of swimming athletes at a national competition level. And the breaststrokers said that they had 7% of them at that point in time, currently had groin pain. 43% of them had adductor pain related in the last year. And if you look at that chart below, 66% reported that at some point in time, ever they had adductor related issues that had kept them out of participation because of that. Individual medley, they said 22% in the last year, 39% had ever reported pain, and then significant drop off there you see to the non-breaststroke or non-individual medley swimmers. So I think for those of us that are taking care of athletes that are swimmers as well as triathletes, if they're doing breaststroke as part of their either training or competition plan, I think being aware of this adductor groin pain as a common issue that they see is something obviously to be aware of. So the presentation of these folks, typically medial groin, proximal thigh pain, and then tenderness to palpation over that adductor longus tendon. In these acute injuries, which obviously is less common in some of the endurance athletes, you can see some ecchymosis, pain with passive abduction and resisted adduction. And you can do this in a couple different positions. You can do this with the legs fully extended, or you can do them like in this picture here with the knees flexed as well. So imaging, typically not indicated, unless there's really a chronic disability or palpable defect. AP x-rays can be helpful if it's an acute injury or there's, folks that aren't improving with non-operative care. MRI can be useful. Muscle strains in those acute injuries with a greater than 50% of cross-sectional area involvement and muscle tears does show that there's a longer recovery time for those. And if there is a palpable defect, usually on the MRI, you'll see a large, significant retraction of those tendons as well. So treatment for these injuries, acute injuries typically resolve with appropriate non-surgical care, as do a lot of these more chronic issues. You know, just like a lot of other things that we do, rest, therapy, rehab, and a slow return to play program. Formal therapy, static stretching, massage, tissue mobilization, return to play after full strength and pain-free motion, typically around 6 weeks. Corticosteroid injections, you know, can be used, you know, I would say sparingly in some of these situations. They can also be used for diagnostic help as well. We certainly have a lot of patients who have a lot of crossover, as we said in the previous slide, between some of this hip groin injury, and sometimes these injections with anesthetic can be helpful from a diagnostic as well as a therapeutic purpose to differentiate between, you know, adductor tendon related pain, hip joint related pain, and sometimes core muscle or sports hernia pain, just because there's a lot of different things that, you know, can present with the similar areas of pain, and sometimes similar physical exam findings as well. And obviously PRP can be used in some of these situations as well. Surgical treatment obviously is very, very infrequent. Failed 3 to 6 months non-operative care, and this usually includes either an open tenotomy or fractional lengthening of these tendons as well. There are some folks in a few centers around the country and the world who are significantly more aggressive with some of these surgical procedures, but I have not seen those to be, you know, significantly needed in our population, that, you know, at least those that we take care of here. So athletic pubalgia, sports hernia, core muscle injury, Gilmore's groin, whatever, you know, there's a lot of different names for, you know, I think maybe not exactly the same, but probably related pathologies. And this is really an injury to the structures that insert on the pubis. There's multiple different things from the abdominal muscles and adductors and things like that as well. These are more common in cutting, pivoting athletes, but sometimes we will see these in some of our endurance athletes. And typically the pain is brought on by activity and relieved by rest. The most common physical exam finding is a tenderness to palpation around the pubis and your lower abdominal muscles, and a pain with resisted sit-up that we have found to be as well the most common and most reproducible physical exam finding, to indicate that, you know, this, you know, pathology, as well as to differentiate between intra-articular pain, adductor related pain, or other groin issues in athletes. And as I said, those physical exam findings can overlap with other issues. MRI can be hit or miss. And the biggest problem with this is that it's really a dynamic problem. And as I said a minute ago, patients typically, you know, have pain with activity and it's relieved at rest. So MRI is typically a static picture of what is a dynamic problem. And so that's why the imaging can be challenging. There are a few athletic pubalgia dedicated MR protocols, and there is some, you know, reasonable sensitivity and specificity for those. But obviously, as you see there, 68% sensitivity is not, you know, it's okay, but not great. Diagnostic injections can be helpful as well. And then one of the other things that we have in here is a dynamic ultrasound, which is a thing that our musculoskeletal radiologists can perform for us, that myself and the folks, when I was in sports medicine fellowship in Detroit with some of our MSK radiologists there, developed this protocol to doing a dynamic images of the sports hernia issues that we have there, and that can be helpful to further differentiate those pathologies as well. Sorry, I'm looking at Melissa's chat here. You're still seeing the notes. Can you guys still see? Can somebody just unmute and just let me know that yes, you can see the actual slides though?
We can see the actual slides. We also see next slide and notes.
Oh, so you're seeing that whole thing there. Okay. Oh, no notes. Gotcha. Here, let me see if I can fix this real quick. Hang on. Where is my Zoom?
Cal, if you are able to select screen 2, a lot of times you might be kind of self-selected to screen 1. If you try screen 2, that might pop over and then just show your actual like kind of presentation instead of what you're seeing. Maybe. When you're into the section for screen
gotcha.
share screen, yeah, it may just be there. You go.
Is that better for you?
Yep.
Okay, there we go. Perfect. Okay, thank you guys very much. Thanks for the help. So there we go. So surgical intervention for athletic pubalgias, core muscle injuries, sports hernias. Obviously, there's a lot of different techniques that have been described, which for me typically means that none of these work better than any other one. It's kind of like if we've got a whole bunch of different names for similar pathology that we haven't 100% figured out what the actual problem is. A lot of these are done in conjunction with general surgery for repair. Some have described open repairs, some laparoscopic. Sometimes there's a hernia repair done with a mesh reinforcement. And there are occasionally that we have done FAI related surgeries when we think there is truly both an intra-articular FAI type injury as well as a core muscle injury that needs to be treated, and good pain relief and return to sports with treatment of these issues. And this is a review here of different core muscle injury repair. Obviously, this is relatively low level data, as is unfortunately a lot in our sports med and physical therapy or orthopedics level 3, level 4 studies. A couple that are done by the same group, Dr. Myers, as you see there, who has by far the largest case series, by about 5,000. So, there are good outcomes with some of these repairs when I think they're appropriately indicated. So osteoitis pubis, slightly different, different presentation. It's an inflammation of the pubic symphysis and adjacent, bone and tendon insertions in that area. It's an overuse stress injury. Similar soccer, football, hockey players, as well as significantly high numbers of this type of injury in runners. It's this repetitive micro trauma. It's a vague, ill-defined pain. These patients are tender right at that pubic ramus. The vast majority really resolve with non-operative care, physical therapy, and then again, injections can be helpful from a diagnostic as well as a therapeutic purpose for these folks as well. And this picture over to the side here is demonstrating a tender-reduced palpation as well as the spring test, which is sort of like a release test where they may not necessarily hurt quite as much, but when you're pressing both sides in there and you're kind of compressing that area together, and then upon a release, there's a significant increase in pain as well. And here's these images. As you see here, x-rays can show just some vague erosions at that pubic symphysis, and then MRI can show edema and inflammation of the bone and the joint as well as the pubic symphysis, sometimes some fluid in there as well. And then the, and this kind of overlaps a little bit with some of these, bone marrow edema patterns, stress reactions that Dr. Miller suggested when they looked at some of their endurance athletes and the runners. And there were a few of these pelvic stress fractures, and this is sometimes what we're talking about. So this is just a quick real review of surgical management of osteoitis pubis, which is very, very uncommon, I think, in most sports medicine centers. A few of these, again, you see these fusion plating or just a curettage with no stabilization, mesh reinforcement. So several different ways to do this, small case studies, but, with relatively decent return to sport numbers with these surgical interventions, but I think infrequently indicated. So internal snapping hip, as I said before, the snapping that you can hear. This represents the iliopsoas tendon snapping over the structures deep to it, which is typically the iliopectineal eminence, just below your anterior inferior iliac spine. And this is an audible, loud clunking that usually you can hear, and sometimes from, across the room, as the joke goes, right? And the movement that typically reduces this is from a flexion, abduction, external rotation to an extended adducted internal rotated position. And sports requiring, these kind of type motions, dancers, runners, soccer, weightlifting, can cause pain as well in this patient population. The treatment for this, is typically, the vast majority of the time, non-operative, reassurance. As long as it's not painful, you can just tell folks like, yeah, that's kind of annoying. But as long as it's not painful, it's typically not a significant problem. Usually reassurance therapy, injections, try to just calm down the inflammation. Sometimes in the iliopsoas bursa that gets inflamed as well. That can be helpful. Surgical treatment, iliopsoas release, that can be done at the level of the labrum, as you see in these two slides here, which is kind of in the central compartment, how we think of it, or you can actually release the psoas tendon at the level of the lesser trochanter. At the level of the central compartment here in the labrum, there's about the muscle and the tendon's about 50-50 here. So if you just release the tendon portion of this and you don't release the muscle, it's really more of a fractional lengthening of that tendon there. And this can obviously be done open or arthroscopic. You know, if doing it arthroscopic, there can be some reduced postoperative pain, reduced failure rate, and fewer complications. There's a lot of controversy, you know, within the hip preservation world about whether doing psoas tendon releases at the time of hip arthroscopy, labral repairs are indicated, you know, or if they actually help with outcomes. There's some large centers that have published recently and argued that doing psoas tendon releases at the time of hip arthroscopy doesn't change the outcomes. And so their argument has been that that's an okay thing to do. The counterpoint to that is if it doesn't change your outcomes in a positive or negative fashion, why are we doing it? And there's another large group that's also published recently suggesting that psoas tendon releases actually degrade the outcomes and decrease your chances of achieving, you know, patient acceptable symptomatic states and MCIDs after hip arthroscopy as well. So I think 15 years ago, there was a significantly higher amount of, or even 10 years ago, probably, of psoas tendon releases being done intra-articularly, you know, through this way, arthroscopically. And I think the pendulum has swung significantly in the other direction, particularly in the last 5 to 7 years. So stress fractures, you know, Dr. Miller obviously covered this extensively. You know, a lot of people ramping up activity, long distance running, those, you know, trying to do a couch to 5K, you know, beginning a season, changing sports, things like that. You know, x-rays, good first step. Sometimes those can show some cortical thickening or beaking. MRI in athletes that kind of fit some of these, you know, typical stress fracture demographic patterns. I have a pretty low threshold and pretty high clinical suspicion, and getting MRIs early. This is one of those things that very, very much would rather be better safe than sorry, and would rather get a, you know, negative MRI not showing a stress fracture than miss one. Obviously tension sided more concerning than compression sided in the femoral neck stress fractures, and Dr. Miller again alluded to that. Some of these, if there's a displaced, and I've seen this a few times, displaced femoral neck fractures that get fixed, and if they get AVN, can be devastating injuries, and otherwise healthy you know, endurance athletes, whether they're runners, triathletes, you know, and those have long running, you know, not just physical, but also psychological, you know, and larger life effects than just not being able to do marathons anymore. So these are typically treated with protective weight bearing and shutdown. Really, you know, like was hammered home, ensure the appropriate nutrition and hormonal status, you know, whether that's an endocrine, dietitian, DEXA scans, stress, you know, surgical indications for these stress fractures or stress reactions that fail conservative treatment, like Dr. Miller's pattern. Like you said, if they go 6 weeks and they're not improving, if this is, you know, in femoral neck fractures, particularly compression sided fractures that are greater than 50% with a fracture line, or they're progressing on x-ray, MRI, or not improving, I think those are surgery indications. Or any kind of a tension sided femoral neck stress fracture with a line x-ray, MRI, those have high risk for displacement and worse outcomes with surgery at that point in time. Here's just 2 quick little cases that we have here. This is a 21-year-old collegiate distance runner who came in the office, you know, relatively short history of pain, a couple months of some vaguely increasing pain, but really significantly increased over the last couple of weeks. X-rays are normal. And this is her MRI here. And you can see the edema that she had at the medial side of the femoral neck, no stress fracture line that was evident. So she was treated conservatively and went back to her running quite quickly, and did well with this. This is another patient who, you know, this is kind of the ones that, you know, really keep us awake at night. And this is a patient, she's a 31-year-old female. She was in process for training for Boston and walked into one of our sports med offices, and Dr. Mark Conroy on a Friday, afternoon, just kind of complaining of some hip pain. And Dr. Conroy got some x-rays and called me, and right away. And we looked at this, and she's got a pretty significant fracture line here. So I don't think there's any real indication or need to get any further imaging on this patient here. As you see, again, tension-sided injury, compression-sided, and this is a significant tension-sided injury with a fractured line that was evident on these imaging, and I just happened to be on call that weekend, so we ended up taking her to the OR that evening on a Friday, putting these screws in to stabilize this, and she did well afterwards, did get endocrine workup and evaluation, and was appropriately treated from that standpoint as well. Did have some hormonal and nutritional deficits that were addressed. So still on anterior hip pain here. So hip flexor and rectus injuries, these, are susceptible to strain, avulsion. These cross the hip joint, serve as a flexors, also cross the knee joint as well. I have, interestingly, just in the past few weeks, a month or so, I think since some of these spring sports have started kicking up a little bit more, several hip flexor injuries, ASIS, avulsions, AIIS, so sartorius, as well as rectus tendon injuries and avulsions. Some of these adolescent athletes, as I think their track season has kicked up a little bit, and some of these folks have not been running much, particularly over the winter. If some of the winter sports were limited in participation for the high school kids, so that's just something to be aware of as well. Soccer players, kickers, commonly injuries as well. And tendinopathy, very common in track athletes. They can be tendon to palpation at the anterior inferior iliac spine, ecchymosis if it's a acute injury, and obviously a palpable defect, but those are less common. So imaging, MRI can characterize if it's a muscle tendon junction or avulsion injuries, or if this is purely a tendinopathy, tendonitis type situation. Treatment for the majority of these folks, non-operative muscle tendon junction injuries without retraction. If this is a significant injury, and that can be a return to play 6 to 10 weeks. Partial tears, tendinopathy, like a lot of the things that we've talked about, relative rest, eccentric loading. And I think there is some role in some of these folks for shockwave treatment, the extracorporeal shockwave therapy, or PRP treatment. Operative indications, not frequent, but occasionally, sometimes these avulsions, if it's greater than 2 centimeters, whether that's a mature athlete or an adolescent with a transitional injury, particularly in high-level athletes, and this has shown good return to play in elite soccer players. We've got a small case series of these rectus-type injuries in weightlifters, powerlifters, CrossFit athletes that we've treated surgically, and a couple of track athletes as well. We've treated surgically for larger avulsions, and they've done well in terms of their return to play. So this is just a picture from a video that we did. This is an anterior approach to the hip, a little tough to see exactly, but you can see the sutures through here. So this is the rectus tendon extending distally. So proximal head end is towards the left, foot is towards the right. And you can see the sutures that we've weaved through the tendon here and use these suture anchors to repair it back down to the appropriate location in the superior acetabulum. There was a case series of 19 elite soccer players and similar repair to this, and all of those were returned to the previous level of play. All right, I'm going to look at Q&A real quick to see if there's anything here.
Dr. Vasileff, we'll have time for Q&A
Gotcha.
here, so you
Okay.
don't worry about that right now.
Okay, sounds good. There's a little break point here, so we'll come back to that then. So lateral hip pathology, a lot of the things that we talk about, greater choke pain syndrome, external snapping hip, piriformis, which can cross over with the posterior hip as well. Greater choke pain syndrome. We think of this, and I love Steph DeStacey's, Dr. DeStacey's talk about, quote, it's not just bursitis. And she's right. It's a combination of this IT band pathology, bursal pain pathology. as well as tendinopathy and tearing of your gluteal tendons as well. And sometimes these can be related to intra-articular pain, as I think some folks that, tend to overfire their glutes or other muscles here to kind of internally splint if they are having intra-articular pain. This causes this lateral pain on the hip as well. Risk factors: increase in substance P that they've shown in some of these basic science papers, increased acetabular version, typically middle-aged and older women, lower femoral neck shaft angle and adiposity. There were some of these folks in the hip scope that came up with kind of a treatment or kind of a predictive index that mostly said middle and older aged women and higher body mass index with lateral hip pain were more likely to have gluteal tendon tears that needed treatment, which I think is reflected in some of these risk factors that we're talking about here as well. And this can cause this. I mean, we obviously, you all do too, but we see a ton of this in the clinic, and this can really cause pretty significant disability. These folks are less likely to be working full time compared to end stage OA and control patients. So this can cause a lot of pain and issues in patients' lives. So the diagnosis, history, and physical exam really is the key. Key is the lateral sided complaints, and really sometimes have to be really careful and specific with patients about this. A lot of times they'll say it hurts to lay on that side at night, pain with palpation over the trochanter in that area, weakness with resisted abduction, pain and weakness with a single leg stance. Sometimes they can have an inability to maintain the level pelvis with that stork stance, and then hip lag signs as well. When the patient's laying in this lateral position, can be indicative of lateral trochanteric, pain related to GTPS. So imaging, ultrasound, obviously relatively sensitive and specific here as well. Still somewhat technique and technician dependent. MRI is also very sensitive, and positive predictive value is good as well. Although kind of like rotator cuff pathology, there is a very, very high false positive. And I think we have to take any kind of, trochanteric gluteal tendon pathology on MRI with a very large grain of salt, particularly in, our 40, 50, 60-year-old, female, just kind of common citizen population that we have. So non-operative treatment is, the key for this. Physical therapy, home exercises, tendon loading modification program, physical therapy, postural re-education, and then sometimes going into injections with corticosteroids or PRP. Corticosteroids tend to be our first line treatment. At least in my hands, in part just because it's, easier. There's less of a barrier to entry in terms of having to set up another procedure, holding off on anti-inflammatories, and the cost of treatment as well. We have treated some of these patients successfully with a 10X, as well as Shockwave. I'm going to review some of that data here in just a second. And then surgery, if indicated for, failed non-operative treatment. Mini open arthroscopic, there's a lot of surgeons that do it both ways. Some people may be appropriate for an IT band windowing just to offload a little bit of stress from the IT band over that area of the tendon. Bursectomy, and then occasionally patch and graft augments can be applied to enhance the healing. And this Sit Like a Man graphic here is a little kind of educational graphic that for some of the females that was passed around just in talking about, postural re-education, not crossing legs, appropriate ways to sit and stand, kind of the man spreading, if you want to think of it that way a little bit, that causes a little bit less pain related to that trochanteric GTPS. So gluteal tendon tears, just a couple MRIs here. You can see this, a couple different slides from the same patient. Significant amount of edema, significant amount of fluid underneath the IT band in this bursal area, and significant complete full thickness tear over the glute medius tendon. And this is somebody with, you can see just a little bit of fluid in the bursa over here, but not terrible. And they do have kind of an undersided partial thickness tear and fluid collection. And this is a patient that was treated conservatively, failed that, and then proceeded to go on to a 10X ultrasonic debridement treatment, and successfully returned to work and kind of her standard, activities of daily living with very minimal pain. So role of shockwave treatment here. This is a study, relatively recently in JBJS last year, which they did a multi-center RCT. They did a 3-series treatment of the shockwave treatment along with PT, and they did show that the patients that get the shockwave treatment as well as the PT, they did improve more quickly than those with the PT alone, and they did achieve significantly higher level of symptom relief, and that was maintained at the end of the study, which was 6 months. And this is, briefly discuss PRP. I know Dr. Berry is going to get into this a bit more, but this is probably the best evidence that we have for using PRP around the trochanter. This is a study from Australia, from Dr. Fitzpatrick, Dr. O'Donnell, in 2019, and they did show that PRP was better than corticosteroids. The initial improvement from PRP and corticosteroids was relatively similar. Corticosteroids was a little bit quicker, but by 12 weeks, a lot of the folks that had gotten the corticosteroid injection had decreased, they're kind of gone back to baseline. And then the corticosteroid injections, like they said, peaked at 6 weeks and not much benefit, whereas the PRP had stayed improved at 2 years out from surgery. So external snapping hip, sorry, I'm going way too long here. I'm going to try to speed up through these. They talked about the snapping that you can see, and this is folks when they will pop their hip back and forth and tell you that they can dislocate their hip. This is typically what this is. Vast majority of these folks treated reassurance, occasionally injections, physical therapy, and sometimes arthroscopic fractional lengthening or releases can be indicated in these folks. Proximal IT band pain, and this is something I've seen more frequently and kind of more recognized, and I don't think is well described in our literature. This is pain over the iliac crest, pain with palpation, and it's more proximal than our typical greater troch GTPS pain. Center of palpation, pain with running, x-rays are normal, and we've seen this edema pattern showing some tearing at the IT band origin, the tensor fascia lata. And this is a patient you can see pretty dramatic, the two different sides. The left side here is totally normal, on the right side, a lot of edema in the origin of the IT band and the tensor fascia lata here. And this is kind of a middle-aged runner who was training for the Buck 50, the stage trail run, and had a pretty significant injury to this proximal IT band pain. Dr. McCamey, we've treated, and Dr. Waller, we've treated a handful of these successfully as well. Piriformis syndrome, I'm gonna kind of skip this over. Posterior hip pain pathology a little bit. This can be intra-articular related to a C sign. Overlap between the hip and back, SI joint pain, gluteal muscle pain, pelvic floor, which is something that we talk about a lot, and then proximal hamstring, which I'm going to get into here for just a minute. A lot of proximal hamstring pathology that we see, a lot in, kind of rapid sprinting sports, as well as chronic injuries are very, very common in runners. Acute injuries, most of the times you'll see this, they'll say they felt a pop. More often in the endurance athletes, they'll complain of this kind of progressive tightness, loss of flexibility, and difficulty with running and walking smoothly. Your hamstring extends your hip, flexes your knee. Typically, it's in acute injuries, it's an eccentric contraction that causes the tearing. Bull riding and water skiing are some of these things that are really significantly high risk for acute injuries. That's been in the literature a few times. Acute injuries, you'll see this significant posterior thigh ecchymosis in large, full thickness tears. There's a lot of bleeding inside that muscle as well. Sometimes you can palpate a defect there. X-rays typically negative unless it's a adolescent athlete, and you can see some kind of an avulsion or ischial tuberosity, transitional fracture injury. MRI is very helpful to evaluate the insertion site. It helps you define the number of tendons that are involved, how much those are retracted, which I think significantly affects your treatment algorithm. Acute injuries, surgical treatment for 2 tendon tears greater than 2 centimeters or 3 tendon complete tears. Non-operative for those single tendon injuries, tendinopathy or less retraction. PRP and conditioned serum has shown some good efficacies, and also in some of these chronic proximal tears. Needle fenestration can also be used in some of these folks, which to enhance some healing. If and when surgery is needed, anchors in the ischial tuberosity, sutures placed at the proximal hamstring tendon to repair and reapproximate the proximal hamstring back down to the bone. Good evidence in terms of return to sport with these athletes. This is a brace which, kind of historically used. I have not used a brace like this in the last 6 years. We actually published a study from OSU showing that in a more rapid return to activity and weight-bearing protocol had similar success as a much more restrictive recovery protocol in terms of the physical therapy and non-weight bearing. So this is a great infographic that came out of arthroscopy relatively recently. This proximal hamstring injuries, there's really a spectrum. You can see there's a tendinopathy over here, partial tear, which an MRI, which they show a sickle sign, which you can see right there, which is pretty clear, and then complete tear with retraction. And I think this helps you understand the treatment algorithm. Tendinopathy, partial tears, and non-retracted complete tears can be treated non-operatively, particularly some of those complete tears without retraction in lower demand folks. Higher demand folks might want to consider surgical intervention for those. Surgical repair, non-responders to non-operative treatment, a true complete tears with retraction are also appropriate indications for acute surgical intervention. Non-operative treatment, activity modification, eccentric strengthening, PRP and shockwave treatment may be appropriate treatments as well. And for those higher level athletes that do have full thickness injuries, expect about a 6-month return to sport. There we go. Sorry, I hustled through the last little bit there as much as I did, but we got a few minutes here.
All right, thank you, Dr. Vasileff. We will go ahead and get into the poll questions for Dr. Vasileff's talk here. So those will launch in just a moment. First question, what is the most common first-line treatment for greater trochanteric pain syndrome? A, corticosteroid injections, B, PRP injection, C, benign neglect, or D, PT and a home exercise program? And you guys are right on the money right off the bat. So the correct answer is D, physical therapy and a home exercise program. We've got one more question here on Dr. Vasileff's talk. We'll wait for that to populate here. The second question, what is the indication for repair of a hamstring tendon tear? A, partial thickness tear with pain for 3 weeks in a runner who's 45 years old. B, full thickness retracted tear 4 centimeters in a 55-year-old nurse. C, 2 tendon tear with 1 centimeter retraction. Or D, chronic tendinosis failed 4 weeks of physical therapy in a 22-year-old track middle distance runner. This one is a challenging one. Let's see what you guys come up with. So the correct answer I have here is C, actually a 2 tendon tear with 1 centimeter retraction.
I would have gone with the full thickness retracted 4 centimeter tear on that one. So maybe I gave you the wrong answer, Kayla. Sorry.
Okay, good. I was wondering.
Yeah, no, you're right. Yep. The 51% of the audience is right. So I was moderately successful with that then.
That's a-okay. Good deal. Thank you for the clarification.
Yes. Well, thanks everybody for letting me participate. I appreciate it.
All right. We'll jump into Q&A next with Chelsea leading us.
Chelsea, we don't have any sound for you. No.
As we're waiting for Chelsea, I have a question for William. I've had several soccer players who had overuse injuries to their hips. So we're getting labral pathologies, but I also talked to some other key players that said perhaps bilateral labral issues aren't as a key issue as underlying tendinopathies, and that we're missing we shouldn't be jumping to labral surgery, but rather addressing these tendinopathies. What's your thought on that?
No, I think you're spot on with that. I think there are, and I think the diagnostic, kind of paradigm can be challenging as well. The overuse injury and the tendinopathy is very common, especially in some of these higher level soccer athletes, particularly those that are playing year round. There's decent evidence that, even in some of the high level high school and collegiate athletes that, MRIs are going to show you labral tears, labral pathology in, 20 to 30+% of athletes. So, those might not always be symptomatic and problematic. That might just be kind of a normal finding in those folks. So I'm pretty conservative with who we indicate for surgery, and we're pretty exhaustive with non-operative measures before we undertake in an intra-articular operative plan.
Thank you. And I'm actually going to jump in for our Q&A here. Chelsea's having some audio difficulty. Dr. Hutchinson, you did a great job answering a lot of the questions in the Q&A. Could you just chat a little bit further about how you counsel patients when you're telling them to switch to a forefoot running strike pattern instead of that heel strike?
Yeah, that's clearly that pattern is something I've learned from my friends in the Netherlands. I actually was one of the biggest negative people against this pattern, particularly because the original evidence was so poor, and that was as anecdotal. They were presenting 2 to 10 people. However, if we're really looking at trying to avoid surgeries, it does appear that this what they call a sports medicine approach, a non-surgical approach first, is reasonable. You're not doing any harm by trying that, as long as they also are aware of what it feels like or what the trigger would be as if they converted to an acute compartment syndrome. So what we've generally done is, this is not something you can do and just say, okay, go start running on your toes and see how it goes, especially with the same training intensity that you have. You have to decrease your training intensity so that you don't immediately overload the forefoot and then get stress fractures in the forefoot and go find Dr. Miller. So that you have to decrease their load and then observe and coach them. So this is going to be a physical therapy, athletic training modification to then get them to start changing their gait pattern, have the support, the new technique of running. And then as they gradually build up both endurance and distance using a more forefoot based running style, then they build up their endurance and training so they don't get forefoot injuries. So for me, I recognize it, but I use my trainers and therapists to do that transition.
Awesome. Thank you so much. Dr. Miller, we had a lot of questions about vitamin D and supplementations for your athletes, especially with a lot of athletes switching to a plant-based or a vegan diet. How do you recommend athletes take their vitamin D supplementations, and what dosage recommendations do you give?
Yeah, so it's very popular for sure, vitamin D supplementation. And I guess I would take a step back to say that, especially in northern latitudes, it's been proven over the 40th parallel north latitude that athletes who train at that level are low on vitamin D almost across the board, especially during the winter months when we just don't get a whole lot of sun exposure between October and April, basically. So the spring and winter months when athletes are training hard is when they're probably at their lowest vitamin D and probably at the highest risk of stress injury. Just keeping that in mind is very important. Almost across the board, when an athlete comes in with a stress fracture, especially if they've had multiple ones, I will start them on vitamin D, minimum 2,000 international units of vitamin D3 per day, even before getting any testing done. If they've had multiple stress injuries, I'll definitely be sending them for laboratory testing to see for sure where they really sit and adjust it from there. But I mean, we're putting on people at very, very, what we call almost mega doses of vitamin D at this point, either orally or injectable weekly, because it's so low and really so rampant. It's way more common to be low on vitamin D than people really think. That's a huge risk factor for stress injury. So the one other thing about it is that most general supplements, meaning like a typical multivitamin that you get off the shelf, is not going to have enough vitamin D to supplement for an elite level training athlete, or probably any athlete really. It's going to have somewhere around maybe 600 to 800 international units in it, which is basically meeting the RDA but it's not really going to be enough to support someone whose bones are being worked as hard as most endurance athletes are. So minimum 2,000. Not uncommonly am I submitting, having people take twice that much. Other thing that people say, well, I drink a lot of milk, even vitamin D fortified milk, doesn't that get me where I need to be? It usually does not. In fact, an 8-ounce glass of vitamin D fortified milk only has about 400 IUs of vitamin D in it. So not anywhere close to what you really need. So unless you're going to drink, again, mega doses of milk every day, vitamin D fortified, it's not quite enough in that situation.
Awesome. Thank you for that. And Dr. Vasileff, a final question for you here. Do you typically have patients get repeat imaging after being diagnosed with a stress fracture, or do you go based off of healing time frame and symptoms?
A little bit of both. I think is the answer to that. I think I typically, if folks are getting better, along an appropriate timeline, if we're worried about, either the pubic stress fractures, I worry less about. The femoral neck fractures, obviously, I'm a little more concerned about. Just the, the progression of those can be, more catastrophic. So those I'm a little bit more aggressive with getting repeat imaging on in terms of MR. But, if it was just a stress reaction, initially, and they're doing better at 6 to 8 weeks after they're symptom free, they're progressing in terms of their, slow, walking, jogging, low impact activities, and doing fine with that, and they're asymptomatic, then typically I will not re-image them. But those that have, actual stress fractures, I am a little more aggressive with rechecking an MRI, just partly to make me feel more comfortable that it is healing, and that they can safely progress back to their endurance, running, swimming, biking activities.
Awesome. Thank you. So we are
Kayla,
going to go. Yeah,
I have a question for Dr. Hutchinson, if that's okay.
sure.
So Mark, you talked about the success rate of fasciotomies for exertional compartment syndrome, and you talked about how relatively low the success rate is for posterior compartment syndrome. I've definitely had that experience, definitely seen that in the literature. My question for you is, are you still doing a lot of posterior releases because of that? And if you are, how are you counseling the patients that have that as far as what their expectations should be for posterior releases?
Well, it's a great question. And the answer is, I still do the releases because they still have positive pressures. And so they will have failed conservative treatment. And then I do a release, but I make sure that we did a study with a pig study that said you have to have 80 to 90% of the fascial release. I think when you're doing the deep posteriors, we're tagging about 60% of a release because you're afraid to go proximally. And so I think we're doing inadequate releases, and that's why they're failing. And so I think you have to be cautious, but you have to be aggressive and complete the release. And then you have to control bleeding at the time, because my biggest complication is either we have a bleed, hematoma, or cellulitis postoperatively. Always that deep posterior side, rarely the anterior lateral side. And so I think you got to do a complete release. And with that, I thank you for, I think it's been a great morning session. I think we got a great start. And I know I learned a lot from both of you guys, and it's been a pleasure to be part of Ohio State University.
The Ohio State University.
Thank you for the correction.
Yes, thanks, Mark. Great to have you with the program.
Thanks, everybody.
Thank you all. We really appreciate it. So we are going to launch into a 5-minute break. So we will resume at 10:37. So a little bit different than the agenda that you saw, but 10:37, everybody come on back to here, and we will just do a little bit of A/B testing during the break. So you can just ignore that. Thank you, everyone.